Good evening. Thanks to each and every one of you being here with us today. We at Jagsonpal are very pleased to welcome you all to the program today, Fogsi-Jogi-E-Picsep 2021, hosted by Aurangabad Obs and Gynae Society. Lycorate Prac sachet contain like alizarin, lycopene, DHA to prevent pregnancy complications. We have injection maintained 200 and 250, 500 milligram depo-progesterones containing alpha hydroxyprogesterone and Endorec tablet. Dear attendees, if you have any questions, suggestions, clarifications, please post in the chat box and Q&A box. Please note this webinar is streaming live on Facebook. The link is already being shared in the chat box. And for future references, we will upload the webinar on Jagsonpal YouTube channel for reference. Thank you so much for listening, and let us welcome Dr. Gurpreet Sandhu, Secretary, Aurangabad Obs and Gynae Society. She is consultant CSMS multi-speciality hospital. Please, ma'am, please initiate this program.
Thank you so much for the introduction. I welcome all the dignitaries and delegates who have logged in for today's prestigious E-Picsep webinar. This webinar is in association with FOXI, Federation of Obstetrics and Gynaecological Society of India, along with JOGI, that is Journal of Obstetrics and Gynaecology of India, and E-Picsep. E-Picsep is nothing but program for inculcating culture of scientific inquiry and pursuit. Day in and day out, we save so many lives. We owe all this success to the research, and investing in research is investing in our future. So that is a reason, basic reason behind conducting this very prestigious E-Picsep program. We thank Fogsi-Jogi for allowing Aurangabad OB-GYN Society for collaborating with us for this webinar. I welcome all the delegates again who have logged in. And to start with the program, we are thankful to Dr. Shantha Kumari Madam, who is the president of FOXI 2021-22, senior consultant and laparoscopic surgeon, Yashoda Hospital, Hyderabad. And next, I would like to thank Dr. Madhuri Patel Madam, Secretary General FOXI, Joint Secretary FOXI 2009, former committee member, FICO, preterm birth, associate editor, Journal of Obstetrics and Gynecological Society of India. Next, I would like to welcome and thank Dr. Geetha Balsarkar Madam. She is Editor-in-Chief, Journal of Obstetrics and Gynecology of India. And we are very thankful to her for allowing us to conduct this program. She's also librarian of Mumbai Obs and Gynae Society. I'll again introduce her when she'll be giving her talk. And I would like to invite our president, Aurangabad OB-GYN Society, Dr. Shewale. She has done diploma in reproductive medicine from University of Kiel, Germany, diploma in endoscopy, founder member MSR, director Shewale Hospital and Ajanta Fertility Center, Aurangabad. She is president of OB-GYN Society, practicing IVF endoscopy since last 20 years. Without any further ado, we'll proceed with the first lecture. The first lecture has been rescheduled because Madam Balsarkar Madam is traveling, and she'll be logging in very soon and will have a lecture. So the second lecture will be starting, that is of Dr. Varsha Deshmukh Madam. Actually speaking, our country, India, is a data-rich country, but we are lacking behind in publications. What is the use of having so much of data along with us? We could be the country with largest number of publications, but we don't do. We are lacking behind. So that's the basic reason how we are supposed to conduct the publications, how we are supposed to present our work. And it also adds to our CVs, and it gives an upper edge to any physician. So it is not just for the students, postgraduate students, it is also for the clinicians who are practicing, who have got lots of data with them, and they can publish that data. So our first talk is by Dr. Varsha Deshmukh, madam. She is a vibrant member of the Aurangabad OBGYN Society. She has done MBBS, MD, FICOG, FAMS. Professor, Government Medical College, Aurangabad. Professor, Government Cancer Hospital, Aurangabad. Past President of Aurangabad OBGYN Society. National Corresponding Editor, JOGI. I welcome you, madam, for your talk on types of studies in research.
Yes. Thank you, Gurpreet, for the kind introduction. Good afternoon, one and all. At the outset, I would like to thank Dr. Anuradha Shewale, madam, who is the president of Aurangabad OBGYN Society, Dr. Gurpreet Sandhu, who is the secretary of Aurangabad OBGYN Society, and Dr. Geetha Balsarkar, madam, to give me an opportunity to talk about this type of studies in research. Now, when we talk about research, what we are actually looking is the analysis of any action. And research means the detailed knowledge of any subject of your interest with a scientific investigation, which makes a technical sense and which adds to the academic activity. To conduct any research, we need a methodology. And what is a research methodology? Research methodology is the specific procedure or technique which is used to identify, select, process, and analyze information about any topic. It will also allow you as a reader to critically evaluate a study's overall validity and reliability. And any research methodology will answer two main questions. How was the data collected or generated? And how was it analyzed? And there are many types of research we all know. And these are the different types of research. If you look at this slide looks slightly scary because it has got many types of researches and studies, and which to a person who is not well versed with this looks like a very busy slide and does not make any sense. However, as we proceed through the lecture, we will gently walk through each and every study design. So at the end of the talk, you will be all able to understand what is a descriptive study, what is an analytical study. Now this is divided into observational study and experimental or interventional study. The observational study is divided into case control study and a cohort study, whereas the interventional or experimental study is again divided into randomized and non-randomized study. A study could be prospective, forward-looking, or it could be retrospective, that is backward-looking, and it can be a cross-sectional study. So as we go through, I hope we become more and more clear about the types of the study. Now, if you look at the studies, the cohort studies, case control studies, and case reports, these are all the observational studies. Whereas the RCTs and the quasi-experiment studies, these are experimental studies. Quasi means the studies which are done, which are historical studies. For example, if we look at the mortality in car accidents without seat belts, in the era when seat belts were not available, and now today when the seat belts are available, this is a quasi-experimental study. Or if we talk about OBS and gynae, if we look at the era where the support during labor was not available. So the rate of LSCS and morbidities in that era, if you compare with today's era when we have that concept, then that is a quasi-experimental study. Meta-analysis and systematic reviews are the studies of studies. Now, what is the importance? Why do we need to select the right methodology? This is because if you select the right methodology, there are so many study designs we have already seen. Every study design has got some advantages, it has got some limitations, some flaws. So if you know both the flaws and the limitations, you'll be able to do a better choice. And you are able to reach the aims of a study if you get the right direction. And when do you get and how do you get a right direction? By choosing the right methodology. It also serves as a roadmap to reach the destination of interest. So if you have the right methodology, we are very sure that you will not be away from your destination of interest, and it will not allow deviation from the task of interest. It is like a jigsaw puzzle. So everything fits in well. Ultimately, you come down to the goal of your study. Now, when we talk about study, we have already seen there are two types as far as the time is concerned: a prospective type of study and a retrospective type of study. Sorry. A retrospective type of study is when you look at the records and analyze the data. That is, you are looking back. You don't have the patient at present, but you have the data available in the records, and that is what a retrospective study is. When you look at the prospective study is that you are along with the patient. You follow a patient along the entire course of illness. You write down the events in a chronological order till the discharge or the death of the patient, and then you compile, analyze, and you present the data. So when you are along with the patient, that is a prospective study. I hope I am very clear about the prospective and the retrospective types of study. Then one more study we have got, that is qualitative study, whereas quantitative study. Now, as the name suggests, qualitative is a non-numerical data. It may be a concept, it may be an opinion, it may be an experience. And the data is collected through text, maybe audio, maybe video. It is a non-numerical data. So this is a qualitative research, whereas quantitative research is when you collect and you analyze the numerical data. That is a quantitative research. Now it will be used to find the patterns, the averages. It would be useful to make predictions. It would be useful to test the causal relationships, and then the generalized results it could be applicable to the whole population. Now, this is the basic difference between a quantitative study and a qualitative study. So now, qualitative study will give you the answer why and how, whereas quantitative study will answer the questions what and who. Now, so epidemiological, again the same slide is repeated. It is divided into descriptive and analytical types of study. Now, when we talk about the descriptive study, we have three subtypes. One is the case report, second is the case series, and third is the descriptive service. So with the descriptive study, you get the answers for what, how, where. Here, you can identify the characteristics, the frequencies, the trends, the correlations, and the categories. Case reports, we all know, it is a detailed report of signs, symptoms, diagnosis, treatment, follow-up of an individual patient. And it will describe an unusual, unfamiliar, rare, or novel occurrence of a disease. However, it cannot be generalized. For example, this is a case report of Amelia. Again, this is a case report of TRAPS syndrome, which is a very rare entity. So in a single case description, which you think is rare, if you can start with the signs and symptoms and presentation, how did you investigate and treat, then that is a case report. Second is the case series. In a case report, there is a single case. When you compile the patients with common characteristics who have the same clinical, pathophysiological, or operational aspect of a disease, or a treatment, or a diagnostic procedure. So it is an observational descriptive research design. So researchers, they usually describe the experience of small group of people, usually 3 to 10. And when the number of cases are more than 3, then it is considered to be a systematic investigation designed to contribute to generalizable knowledge. Now, it could be done retrospectively, that you look at the records, or it can be done prospectively when the patients are actually with you. You note down the important points and then you discuss it. So this is an example of case series, 5 cases. Concordant congenital abnormalities in twins, report of 5 cases. So this is a example of case series. The third is the cross-sectional service. Now this is the entire population. Here, this is your target population. You take out a sample of population and then you study. Maybe you study distribution of health problem in that population. Maybe you assess the risk factors of some hypertension in that population. So what is it used for? It is used to set priorities for disease control, and you examine the evolving trends like before vaccination and after vaccination. Say, for example, COVID. So what was the status before vaccination, and now what is the status after vaccination? So you have to understand that this is taken over the same period of time in a vast. Now this is the whole population. This is what we have taken a small sample out of it and we are testing it, and then we say that this is the thing which exists. There is no follow-up. There is no assessment after that. There is no prior history. It is only the present thing that you are going to consider. This is a cross-sectional study. What is the advantage? Advantage is it is less expensive. It is easy. It will measure the burden of some illness, of some disease in that particular sample size. This is the importance. Are there any disadvantages? Yes. It does not study the disease etiology, and it is not good for rare diseases. A disease which is very common can be studied very nicely with this study method. Again, we come to the same slide. The second group is the observational study. Observational studies are divided into cross-sectional studies, case control study, and cohort study. This is a part of analytical study. So studies are divided into descriptive studies and analytical study. Analytical study is divided into observational study and experimental study. Again, this is a repetition, but we will need it very often to understand. Now, analytical study, we are talking about the observational study. As the name suggests, observational, there is no intervention, but there is always a comparison in 2 groups. Whenever you are doing an analytical study, there is a comparison in 2 groups. Now, as I've already told you, it is of 3 types: a case control study, a cohort study, and a cross-sectional study. Now, what it is, let us see. A case control study will move out from the outcome towards the exposure. That means outcome has already occurred. For example, CA cervix, it has already occurred. Now we want to find out what is the role of HPV virus in the causation of CA cervix. So a case control study can be taken. Sorry. So what is the study design? I told you it starts with the outcome and goes to the exposure. So now these are the cases. Say these are the cases of CA cervix. You go back and find out how many are exposed and how many are unexposed. Now, these are the controls who do not have the CA cervix or who do not have the disease. And you go back and you find out how many are exposed and how many are unexposed. So this is the onset of study. The time is moving here, but you are going in the past. This is the study design or basic concept of case control study. I hope I am clear about it. Now, so the study begins over here. These are the cases. This is the control. You go back and you find out whether the exposure is there or no. Is there or no in both the groups. So this study will move from the backward direction, from outcome to exposure. The backward time, the study begins after the outcome. This is a typical case control study. Again, the same thing what I have taught, CA cases, CA service cases, and the controls. So you move back and you find out what is the exposure of HPV in both the groups. And then you note what is the exposure odd in this group and this group. And then you find out what is the odds ratio. The odds ratio will tell you about the exposure in the cases as well as in the controls. To find out the odds ratio, so what are the things which are needed for a case control study? You will need the cases, that is the people with the disease. So there should be a clear definition of the disease. Then you will need the controls. That means a matched population with age, with gender, with whatever socio-economic status, with height, weight, whatever is the factor which matters without the disease. Once you have these two clear definitions, you will need the information about the exposure. Once you get this information, you will do the analysis of the data, which has to be precise and accurate. Now, for doing the analysis, you will formulate a 2x2 table. This is exposed and non-exposed. So total population, exposed, non-exposed. These are diseased and non-diseased. In other words, cases and controls. So total people who are diseased, total people who are not diseased. And then this out of exposed, this many had disease, this many did not have disease, and these were the total people who were exposed. Out of non-exposed, this many had disease, this many did not have the disease, and this was the total of the non-exposed population. This is the whole of the population. This is a total of the non-diseased population. This is the total of the diseased population. I hope I am clear about it. So to calculate the odds ratio, the formula is probability of the event divided by probability of non-event. So the formula would be AD by BC. So the odds ratio could be 1, it could be less than 1, it could be more than 1. So if it is more than 1, then the exposure will increase the disease risk. This is definitely a risk factor. If it is equal to 1, then exposure and disease, they are not associated. I mean, there is no correlation. And when it is lower than 1, then actually exposure will reduce the disease risk. Now, for example, there is a village of 30,000 people and we want to see the same formula, CA cervix, HPV exposure, positive and negative. The same 2x2 table we have calculated. So in that village, there were 15 cases of CA cervix. So we have taken a sample of population of say 315 women. And we have seen that 110 women were HPV positive, out of which 10 women developed CA cervix, 100 women did not have CA cervix. HPV, 5 women had CA cervix, 200 had no CA cervix. So this was our table which we divided. Now, because we have done a case control study, we need to find the odds ratio. As already told, AD divided by BC. So if you look at this table, A, B, C, D. So AD divided by BC, this comes out to be 4. So odds ratio is 4. It is more than 1. So it is definitely the risk of HPV and CA cervix, they are all, it is associated with HPV exposure. CA cervix is associated. There is a definite correlation or association of HPV with CA cervix. This is the conclusion. So what are the advantages? This is a quick, inexpensive study and good if there is a long method spread. However, the disadvantages, you cannot know the incidence, you cannot know the prevalence. It is not suited to study the multiple outcomes. But what is important is the controls are very important. They should be properly matched. Otherwise, the analysis is going to be different. The outcome is going to be different. So in a nutshell, the cases and the controls, they have to be clearly defined, and they have to be, there should be no confusion about the definitions. Next, we go on to the cohort studies. Now, cohort is a Roman word, and it implies a group of men with similar characteristics, and they are moving ahead. This is an army, Roman army. And cohort is the word which is used to describe an army. So it is a group of men with same characteristics. So what picture I've shown is 300 to 600 men unit in Roman army is known as a cohort. Now, cohort studies could be prospective or they could be retrospective. So if you talk about the retrospective study, you have to see that the study starts, you have to see whether the exposure is there or not, and what is the outcome which is there. Whereas in retrospective study, the study starts over here and you find out along the period of time what was the exposure and what is the cohort study. The study, this is the exposed to risk factor, not exposed to risk factor. This is the present. We start the study and then we move along the time, and then after a particular time, we find out whether the disease is present or absent in the risk factor exposure group, and how many with the disease are there and how many without disease are there in the not exposed to risk factor group, and then you find out the relative risk. So the outcome, the design is exposure to outcome. Whereas in case control study, it was outcome to exposure. Again, the same thing has been, this is the whole population. You take a sample size. These are the people with risk factors. These are the people without risk factor. This is the present. You follow this sample over the period of time and you find out how many are with the disease and without the disease in the risk factor group, and how many are with the disease and no disease in the absent risk factor group. I hope I'm very clear about it. I don't know what is happening to the slides, why they are moving so fast. So this is an example of prospective cohort study. 2018, this study was started between the smokers and non-smoker. None of them had the disease. These people, they were followed over 10 years. So in 2028, we tried to find out in the smokers group, how many had lung disease, and in the non-smokers group, how many had lung disease. This is an example of prospective cohort. Now, these are the different studies which we have in OBGYN. Like this is an example of prospective cohort disease study. Diagnosis, treatment, and follow-up of women undergoing conscious pain mapping from chronic pelvic pain. Now, this is a study which the type of study is a prospective cohort study. Whereas the effect of mode of delivery and duration of a labor on subsequent pregnancy outcome, it is a respective cohort. Obviously, the study title tells you about the type of the study. So these are the types of prospective and retrospective cohort studies in OBGYN. And this is the study which a prospective cohort study to assess and correlate the maternal periodontal status and their pregnancy outcome. This was published in JOGI. I'm going to talk about a very famous study, that is the Framingham study, heart study. This study began in 1948. They defined the risk factor and the study started. The next generation, that Framingham offspring study, it started. The next generation was studied. The third generation was also studied. So this study started over here. Framingham is a village, was a village in 1948 in UK. And then they started this study. Now this has become a very huge study. And then this study was conducted and continued, and the third generation is being studied now. So this is a very important example of prospective cohort study. So like this study was done to study the heart, the risk of CVD. So what did they do? They studied people who had hypertension. The second one was people who were normotensive. Now these people were followed over the period of time. And then at the end of some years, they found out how many had a cardiovascular disease in this group and how many had a cardiovascular disease in this group, and they compared the incidence, and they concluded that hypertension has this hypertensive patients, they have a very high risk of CVD. This is the concept. I gave an example of this study to explain how a prospective cohort study is done. This is another example. We need to understand the determinants of heart disease in a woman. So we start the study. We enroll and we assess the exposure. Suppose we say we take two groups, obese group and lean group. And then we follow this woman every 2 yearly up to say 20 years or 40 years, whatever. And at the end of the study, we compare the incidence of heart attack in both the groups. Now, as you can see, obese women are more prone to have a heart attack at the end of some period. So this is an important, again, type of study, a prospective cohort study. Now, what is the example of retrospective study? I want to study the, say, aniline dye, whether it causes CA bladder. So what I do, I go back in the factory where aniline dye is used. I will get the employee health records and I will find out the employees who were exposed, that is, who were actually working in the factory. And I will take some example of the people who were doing the clerical job in the same factory, who were not exposed. And then I will look at the records, and that was, say, in 1985. And then today I will go and find out how many had CA bladder. Was the risk more in the exposed group or the risk more in the non-exposed group? So what is the risk associated with aniline dye and CA bladder? So now this is a bit confusing if we look at the cohort type of studies and case control studies. So cohorts type of studies will go in this direction, that is exposed and non-exposed, and then you will find and compare the incidence. That is, the outcome of the disease is occurring later. Whereas in case control studies, the outcome has already occurred. Now you are going back and finding out what were the exposures and comparing them. This is the basic difference you need to understand when we talk about the cohort type of study and a case control type of study. Now, what are the elements of a cohort study? You will find to select the study population. Once you select your study population, you will need to find the baseline information about the data, baseline data, the exposure of risk, or whatever the risk factor, whatever the details you want to test. You have to exclude the individual with the disease. People already having CA bladder and going and working in a factory where aniline dye, that is not going to make sense. Or people who already had CA or already had a heart disease, whether obese or, that is not going to make a difference. So you have to exclude the individuals with the disease, obtain the data on covariables. If time permits, I'll tell you what is covariables. And the comparison groups, they have to be appropriate. They have to be very well matched. And then you have to follow up. The follow-up has to be uniform and complete in both the groups. And then you ascertain the exposure and you ascertain the outcome. Here, again, your definition should be very clear. And then you do the analysis. For the analysis, you have again a 2x2 table, exposed, non-exposed, incident disease, and no disease. A, B, C, and D. Again, the same formula, the same type of table. And now, you find out what is the relative risk, the risk of exposure in the the risk of getting the disease in the exposed group versus the risk of getting the disease in the non-exposed group. Incidence of disease among the exposed and incidence of disease among the non-exposed. So if you look at this table, according to this formula, the formula is A divided by A upon B divided by C upon C plus D. So if the RR comes out to be more than 1, that means there is a positive association of the risk factor and the disease which is involved. If it is equal to 1, that means there is no association. Whereas if it is less than 1, then it tells that the risk, whatever you were thinking as the factor, may be actually protective or negative association. Again, we come back to our same formula and same village, 30,000 population. And there are about, 30,000 women. And now, because this is a cohort study, you see what is happening. HIV positive and HIV negative women, women who had CA cervixes, and women who did not have CA cervix. So HIV positive were 10,000, for example, and HIV negative were 20,000, for example. And I now want to calculate the RR for CA cervix. So this being the formula, now A upon A plus B divided by C upon C plus D. This will give me the RR, and this comes out to be 4. Again, it is more than 1, so there is a strong risk. So RR will tell you 4 times more risk. It will tell you about the risk. It is more intuitive. Whereas OR will tell you a association, because this is directly available from the logistic regression. What are the advantages? Advantage of cohort study is that it is the best way to ascertain both the incidence and natural history of a disorder, because you are following the patient, the population, over the period of time, and you are witness to the events which occur in the disease. There are so many advantages. And the disadvantage is that loss to follow-up is a very big problem, because this study design essentially needs a good uniform follow-up. So if loss to follow-up is there, then the study can give you different results. But the study is also time consuming. It can be expensive, all those things. Sorry. Now, we come to again the same slide, experimental type of studies. So they could be clinical trials, and they could be, these clinical trials could be lab trials, they could be field trials. Now, clinical trials, what are clinical trials? Clinical trials translate the basic research into better ways to prevent, diagnose, or treat a disease. It is commonly conducted to evaluate a new drug, a new treatment, a new medical technology, a new delivery system of healthcare, any method of primary prevention of some disorder, or can also be implemented to see the programs for early detection or screening of some diseases. So clinical trials are conducted for this. Now, what is the study design? This is a sample population. The population is at random divided into 2 groups, group 1 and group 2. One group receives the new treatment and the outcome is found out, whereas the second group receives the control treatment and the outcome is found out. And then we find out whether this new treatment is better or whether the control treatment is better. Now, this is the basic idea of conducting a clinical trial. Now, again, we come down to the same thing. Study population, we just give a finishing touch. We apply our exclusion and inclusion criteria, and we find out the appropriate study sample. We do randomization. This is our intervention group. This is our control group. We do the intervention. In control group, maybe we don't do any intervention, and we study the outcome. So over the period of time, this is what is done. This is the basic study design in clinical trial. So clinical trial is a planned experiment design to assess the efficacy of some treatment. Maybe it is prophylactic, maybe it is therapeutic, maybe it is some diagnostic, some agent, some regimen, some device, some procedure. It is essentially done to, it is applied to human subjects. And then we compare the outcomes in these two groups. In a group where patients are treated with a test treatment, and the other group would be those who are observed with a comparable. These patients are comparable and who receive a control treatment. And this is a prospective study where the patients are treated or exposed to intervention and followed over the same period of time. Now, how do we do the randomization? The randomization should be done, the groups, in a way that both the groups should be similar. This will avoid the co-founding, the bias, the co-intervention. Now, these are terminologies. If again time permits, I'll tell you, because these are something which is something again which has a wide base and definitions. So, to avoid confusion, these groups should be similar. That is the basic message I want to give in this slide. Now, I don't know what is happening to the slides. There is blinding. Now, what is blinding? Blinding is that there are two partners or three partners in any research. One is the patient, second is the doctor, the treating physician, and third is the researcher. So a study can be single-blinded where the patient does not know what intervention or what treatment he is getting, but the doctor knows. It could be double-blinded when both the patient and the doctor does not know, but the researcher knows.
Madam,
whereas it could be triple.
We'll have to see
triple
time.
Yeah, madam, I'll be fast. 40 minutes are over. It could be triple blinded when the researcher and both doctor and patient, they do not know. What are the advantages of blinding? It gives better outcome. There are 4 phases of RCTs. The phase 1 is the study effects on a healthy volunteers, 50 to 150. Phase 2, we become slightly bold and we treat 100 to 200 patients. We know increasing, we have a knowledge of the drugs effects and the safety. The phase 3 is where we have 500 to 5,000 patients. The number of patients would be increased, a placebo would be introduced, the RCT would be conducted, and then phase 4 goes for in the patients, actually in the clinical scenario. RCT example is postmenopausal women selected from population. They are randomly assigned. A study group receives HRT and control group receives placebo. Both groups are observed prospectively to see who develops CA endometrium and then compare the rates of CA endometrium in both the groups. These are the advantages. I'll go fast. I'm sorry, ma'am. I'll just take 2 or 3 minutes now. I do not want to exceed the time. These are the advantages and disadvantages. RCT has got an ethical body, a regulatory board, a scientific board, and all these boards would be regulating the RCT. The scientific body will find out whether the research question is sound, what is the methodology which is applied, whether it is correct, whereas the ethical board will consider what is happening to the informed consent, when the triads, what are the triads proposed rules, how is the documentation, what about the grievances, what about the safety assessments, are the human subjects harmed in any way, whereas the regulatory board will look about where from the finances are coming, how is the intellectual property, all those things. The last part of my topic, systematic review. This is, as you see on this pyramid, this is the last and the very important. Along with comes the meta-analysis, but that was not allotted. So only I took the systematic review. It is, you identify a question, a primary research question, and you extract data pertaining to that question, and you analyze the data. And the purpose is to deliver a meticulous summary of all the available primary research in response to a research question. Now, there are different phases of this systematic review. One is the planning, second is the conduct phase, and third is the documentation phase. Planning is your team gathers 2 reviewers or 3 reviewers. They define a question and they create a protocol, they plan the method, strategy, they register. Now, time does not permit me to see how the protocol is registered. I cannot give you the details, but I wanted to actually talk about it. Then second is the conduct. In this conduct, they go for exhaustive and transparent, repeatable search for the evidence and for selecting the studies. Once that is there, they think about the documentation where data extraction, synthesizing the evidence is there, and then they draw conclusions, they write and they publish, right? When you do meta-analysis, it is the analysis of whatever data is available. Here it is just compiling all the data and writing. So to summarize, the main advantage of a good research design is that it provides accuracy, reliability, consistency, and legitimacy to the report. So case reports and series are the series on patients with an outcome of interest. There is no control group. Whereas cross-sectional studies like Sensex, example is of Sensex at symbol type point of time, you have an observation of a defined population. Then the case control study is it will begin with the outcome. It do not follow the people over time. Whereas a cohort study is, it could be prospective, it could be retrospective, where a clinical research study in which people who presently have a condition or receive a particular treatment, they are followed over the period of time compared with another group who are not affected by the condition, and then the this thing is compared. In RCTs, it is a controlled clinical trial that randomly assigns participants to more groups, and then there are various methods, and then the outcome is assessed. Whereas in systematic review is a summary of the clinical literature. Do I have the time or I do not have the time?
No, madam. No, madam.
No. Okay. 1 minute. Exercise improves blood sugar control in diabetic patient. How to do a descriptive study? It could be a case report, case series, cross-sectional. I do not have the time. The same. I want to do an analytical period. So this would be my question. I could do a case control study, cohort study, and cross-sectional study. This is my example how I will conduct my study. Systematic review, I'll do the step 1, step 2, step 3. Thank you so much. I'm very sorry for exceeding my time limit. Thank you, madam.
Thank you so much, madam. You were sharing your enormous knowledge that you had. Madam has presented over 70 papers, madam, publications. She has got to her credit. So thank you so much, madam. That was an excellent presentation. And now we will switch on to our next topic. And for that, I invite Surgeon Captain Dr. Sushil Chawla, sir, Professor and HOD Obs and Gynae, INHS Kalyani, Visakhapatnam. He's an MBBS, MS, DNB, graduate and postgraduate from AFMC, Associate Editor, MJAFI, National Editor, JOGI, Reviewer of for BMJ, and sir is corresponding editor, JOGI National Faculty. Welcome, sir.
Thank you very much, Dr. Sandhu. First of all, I thank my friends who have given me the opportunity to be part of this workshop on scientific writing, and topic often neglected. And once I got this, I did not know whether it's a science or art, because that was the question in front of us when we passed our 10th class also. To go for humanities or to science, and ultimately to make a combination, we are here as doctors. So this is what we'll be talking for next about half an hour. You have any questions, put it across, take my number, you can talk to me directly. I've been told to talk on IMRAD format, how to show graphs, tables, the common errors, and something of ethics in publication. What is a good paper? Everybody wants to write a good paper. I should publish in BMJ. It's a good paper, good journal. So what makes a good paper? First of all, be happy. Be thankful to God that you have finished your research. You have finished your hard work. Now it needs to be published. Whether it was a thesis which you made for the university, or this was your research experiment which you want to publish in a journal. So before you start, whatever it is, either the university or the journal, you should be clear what are the requirements. So always read instructions to the authors. That's an important thing you must, I repeat, must do. If you do not, because this requirements and instruction to the authors will tell you what are the things to avoid. And if you know what are the things to avoid, we are not going to get into a situation where we get a mail saying something on this, that we regret to inform that your article has been rejected. So please be clear. You should be always knowing what are the instructions to the authors. Then next, we should all realize what are the type of audience who will be reading our paper, who will be reading our research, what we are going to write. Remember, our first audience is the referee or the editor of the journal where will be submitted. So first job is to convince them. If the editor, whether it's the technical or the subject editor or the reviewers are not convinced by our work, it will never reach the whole scientific community where we want it to go. So that means you need to convince both of them. And next come to the IMRAD format. Now, what is IMRAD? Everybody wants to talk about IMRAD. So what is IMRAD format? IMRAD stands for Introduction, Material and Methods, Results, and Discussion. And if I had time, which was at premium, I would have finished my presentation by this slide. What is IMRAD? It needs introduction. That means we are looking at what is the problem, how do you intend to solve it, and when we solved it, what did we find? And if we find something, what was the significance and what does it mean to the scientific community? So that is where you come to IMRAD format. Now, as you see, it proceeds from introduction to material and methods, results, and discussion. And since time immemorial, when we joined school also, we were told always proceed in a scientific manner. So although in this lecture, we will be proceeding in the same IMRAD format, it was always told to us, always draw an outline. So we'll be starting with introduction. Introduction is something like where we are proceeding from a broad topic to narrow. Something like when you start writing an introduction, we have variety of thoughts about a topic. It's a topic which is broad in our mind. Let's, in our minds, take a question on comparison of use of injectable ferric carboxymaltose versus oral ferrous sulfate in prevention of postpartum anemia, a randomized controlled trial. Now, all of you can write your points as we proceed further. So we're going from broad to narrow. What is the first thing we want to know? We want to share what is the background information. What do you know about this topic? That means if you're talking of postpartum anemia, what is known about postpartum anemia? Why do you want to study it? How is it affecting the society? And if we are going to talk about ferric carboxymaltose or oral iron, how is it going to affect postpartum? So whatever is required is already collected. The next is, what is the gap analysis? That means what is already known, what people before me or before us have worked. They were not fools. They worked on the topic. Most of the solutions have been given. Some we are also supposed to find and help the humanity. So if they found out, what did they find out? Are there some limitations which they faced? Are those limitations over? Can we cover those gaps? So that is what is analysis of gaps, and how do you intend to fill those gaps in this study. After you have this, the background knowledge and what is not known, You try to form a research hypothesis or the research question, which tells you what are the aims and the objectives. Why do you want to fill those gaps? Why is it important? So you start giving a research hypothesis with a brief summary of a research method which you are going to follow during this research. The next paragraph in the introduction is the significance, what you found out, a brief significance, and how this findings are going to impact the future of us. So as we go ahead, we have realized introduction when we are writing, it can be simply said in these four photographs: context, need, task, and to preview it as a movie. But coming to a little hard task, an introduction should be about 3 to 4 paragraphs, comprising about 10 to 15% of our paper. Complete, as I said, always draw an outline. So as we said, it goes from IMRAD. But if I have to write a paper, what I do first, I write all other sections starting from tables, methods, results. Because as you saw, introduction covered portions from everywhere, from methods, from results, from discussion, and obviously it had some. So we should have a rough draft of other sections so that we have a bigger picture in front of us and we should be clear what we'll be writing. A reader after introduction should have a very clear idea what he is going to get from the rest of the paper. So always I'd say, please draw an outline of the introduction, what you're going to write. Do an extensive literature review so that you should have a knowledge of what is missing. Present a gap analysis and a research goal briefly. A summary of results. After you have written, put it all together, use a good language, grammar, polish it, and write an introduction, which should be very, very clear and appealing to the reader. Use few keywords and academic phrases. I'm giving few examples, something like, it has been widely adopted when you're talking or starting the introduction. When you're talking about the gaps, the challenging problem, something like this. When you're talking about the methods or the new techniques, as you talk about what are your findings, what are your goals, and what are the future endeavors by this study, can go ahead. So as I said, it's something like a funnel effect as you're coming from broad to narrow, from background information, gap analysis, hypothesis or the research goal, and obviously the results and the significance of the findings. Coming from introduction to, as I said, material and methods. This is the heart of our presentation of article, because this is what gives the validity, credibility, and reliability to the article. If this is not good, it has flaws, it will be straightaway labeled as poor study. When as an editor, I'm reading an article, the first thing I go is material and methods. And you can imagine what happens if I find flaws. It should give a clear and brief description of procedures, and each procedure should be systematically explained. All necessary details need to be coming as I'll be covering it. Always write it in past tense, in a logical and chronological order. Give it to your friends or your colleagues after you have written to read. If they can understand the procedures which you have explained, if they cannot, rewrite it. Organize the subheadings in the same order as you'll be writing in the results or vice versa. Whatever were the experimental materials, you should always, whether it's humans, drugs, animals should be mentioned. The protocol needs to be mentioned in detail. What are the type of studies, as Dr. Varsha said just before me? What was the study population, controls? What was the duration of the study? How was the sample size calculated? What were the intervention done? What was the method of randomization and data collection? So all this needs to come in your protocol. That means something to the para 2 of the study, it needs to come. What are the methods used to measure the results? How were the data which you collected was analyzed? Whether you went for mean, mode, median, standard deviation, it all depends upon your type of study and the data collected, whether it was quantitative data or a qualitative data. If it required, whether any normalization of the data was done, how is the blinding done, if any, what were the statistical methods which were used, and if a statistical software was used, it needs to come here in material and methods. If any equipment was used, the manufacturer's name, the model, and the type of instrument must be told in the article. And last but not the least in methods, institutional ethical committee approval letter and a CTI registration number, if any, needs to be given in bold in your article. You should be very clear when you're writing. It should be in past tense with all complete details coming in materials and methods. What are the common flaws when writing material and methods? The small and biased samples or insufficient samples. Incorrect research tools are used, or they are correct tools but described incorrectly. Inappropriate use of statistics leading to incorrect interpretation. And most common flaw is it has been written in a manner which is unclear and is hard to follow. So this methodology, if it is hard to follow, no reader is going to proceed further. Coming to results. Often I meet my friends or sometimes students who come to me and say, sir, I've got so much of data. I've got so much of data. Help me. Help me. I want to write paper. What is data? You conduct an experiment. Whatever were your findings, that is what is raw data. That is a gold mine, yes. But remember, gold lying in mines is not the same price at lying in the jeweler shop. So if you only have raw data, you'll be like my friends and colleagues who will be holding their heads because they just collected without any hypothesis or anything else in their minds. So you should be clear. This data needs to be analyzed. And once it is analyzed, then only you get something called observation or results. So plain raw data is not part of the article. It needs to be analyzed and presented in a logical manner to be read by the readers as results. So readers will be happy if they can understand those results which you have presented. The tips and tricks for the data are always present in the past tense. Always focus and prioritize on some to show important result which support or reject your research hypothesis. As I said earlier also, the paragraphs or sub-para in the results should be the same what you used in methodology. If you have collected some important data, but which is not supposed to be part of this study, use it as a supplemental material and submit it to the journal as a supplementary material. How do you do it? Now, when you start writing results, first and most important, always state the research question or research hypothesis in your mind again. Is this what I started with? Then only come to those results. If your research question and your results do not match, this paper is as useless as lying in a toilet room. So always present whatever you have collected in a logical sequence. As you said in methodology, go from one to the other point which you went ahead. There are methods of presenting the results, that is text as well as non-textual. Text is used for describing the results which you have gone mostly in descriptive studies, while in non-textual format where we use graphs, figures to either compare various groups or patterns. You can use tables, large quantities of data and exact values to be shown by them. But always when you're numbering them, there should not be any mismatch. Now, when you present tables and figures, you should be clear what you are doing. Now, this is a figure. See what is shown. It is figure number, the labels, what is the legend, what is the heading, everything, whether it is on the horizontal or the vertical axis, everything is clear. Always when you are using, always use a well-selected scale. Axis label size should be clear. You should be writing only in a horizontal manner. Okay, so you should be very, very clear when you are writing. When you present this figure to a colleague of yours, he or she should be able to understand this figure without any text or any explanation being given from you. Similarly, when you are putting the table, each needs to be the number, the title, the headings of columns and rows, and the data. As I said, this table by itself alone should be self-communicating, and you should not be need to explain it in the text because that will lead to duplication. Avoid overcrowding inside the tables. That will not help. So once you have crowding, it is not going to. Okay. Now, which tables or figures to use? It depends upon the type of data you have collected. If you need to compare, you can use a column or a bar or a pie diagram. If it's a discrete data, you can go for a line diagram. If you're showing trends, you can again go for a line diagram. You should proceed systematically and highlight the important findings in the text. Now, how much should be the result? As I said, introduction was about 10 to 15 or 3 paras or 4. It depends on how many were the primary objectives which you started with. If you had a single objective, you need to emphasize only on that. So it may be probably 1 or 2 tables or about a paragraph of text. If you have gone ahead, you need more. At the end of writing your result, this should not be the condition what you are. Can you understand anything from this? I couldn't. Never ever discuss your results in the result section. You have a separate D for that. This is a minefield for any researcher. Should I publish my negative? You must. As the word research shows, you are looking for something new. It may positive, it may come as negative. It has come negative, do not ignore it. It needs to be shown to the scientific community. Do not present raw data, as I said. Never be vague words like good, bad, small, big. Do not repeat the same thing again and again. So decide a single table and a graph or a 20 tables and 5 graphs. Anything which is being shown as a result should have been shown in methods or vice versa. Whether you want to compare proportions and relative amounts, as I said, it goes to bar chart, trends goes to line, what's typical again goes to, and correlations go to a scatter diagram. So what is a good result section? It only confirms or rejects the research problem in your own study. Do not ever generalize it. The tips here are direct, avoid repetition. It should only answer your research question and there should not be any mismatch. Discussion. It is the most creative and storytelling session. It is an opportunity to defend your answer to your research questions and create argument to support your conclusions. Here, as I from introduction, we came from broad to narrow. Here we are going from narrow to broad. Okay, it is generally written in 3 or 4 paragraphs. It should have a beginning, a middle part, and the end. The beginning is the important is how to start the first sentence or the first paragraph. This should state the importance and new findings of your research and should always include what you mentioned in the introduction. In the middle part, it is the interpretation of your results. So you need to defend your answers. This is the time where you are going to compare your own study with the studies which have been, or the work which has been done previously. This is an opportunity to say the strength or the weakness or the limitations of your study. And the last is something which is going to say what is the final results of your study or the conclusion, and what is the significance of what you have found on the future research in this topic. So that is how you go ahead. What's the tip? Highlight the significance, avoid generalizing or misinterpreting the result, and do not draw conclusions without any supportive findings. Now, coming to publication ethics, there are 5 ethics, that is ethical review by falsification and fabrication of data, authorship, plagiarism, and conflict of interest with submission ethics. Here I'll be discussing only authorship and plagiarism. Now, what entitles you for an authorship of an article? Presently, it is mandatory by every journal to declare contribution of each author. So when should it be decided? Decide the authorship while you are writing the protocol of the research. Each individual or each author should be very clear about his or her responsibility, because credit, it gives accountability and responsibility as for the authorship as well as the research. So International Council of Medical Journal Editor recommends the 4 criteria for authorship. What are those criteria? That means there should be substantial contribution in the concept or design, acquisition of data, analysis, and interpretation of data. The person should have given good contribution in drafting or revising the article for intellectual content, should have given final approval of version to be published, and should be in agreement to be accountable for all aspects. So these criteria need to be fulfilled before you get the authorship. It is just not putting the name which comes. Now, who is not an author? Somebody who has just given you money. It was general supervision, like it is being done in a medical college. So dean does not become the author. If unit 1 was doing, or unit 3 was doing, HOD may not be coming in the authorship. Just providing an administrative support, something coming from the Adam block, somebody who just help you with the computers. These are not the criteria which gives an authorship to an individual when writing a scientific or a biomedical article. Now, what is plagiarism? सीधा साधा हिंदी में चोरी. कैसे चोरी करी? अपनी करी, दूसरे की करी, अपने ही सामान को तोड़ के करी. This is what are the types. Direct. You wrote an article, I found it interesting, I took the word to word and put it in my article. That is what is direct plagiarism. I wrote an article myself. Now, when I write a second article, I take something from that, put it inside as well as put it in citation. So, self-plagiarism. अपने ही घर में चोरी. I did an article, as I said, something on which we were doing FCM versus oral iron and postpartum anemia. At the end, initially I started with the research hypothesis, and at the end I say, okay, let's get 3 articles out of this. One will give me prevalence of anemia, one will tell me this, and that is what gives you salami publication. So do not end for something like, because today it's easier to pick up when you're writing this. Everything is digital, and so avoid plagiarism. Simple, avoid copy pasting, write concept in your own words, spend a little more time when you're researching. Remember, research is really time consuming. It doesn't go easily. Acknowledge the original sources. Somebody has worked hard. Cite their names accurately. Avoid, as I said, writing articles of the same type, and obviously anti-plagiarism tools are available. Remember, research, as I said, is a hard work. So the stairs may not end in your short career. Be prepared to walk higher and higher. And if you walk it correctly, it will take you to zenith. So start writing logically, truthfully, and your brain will always support you. Thank you very much. That's the end. I thank the organizers once more. Thank you very much.
Thank you very much, sir, Dr. Sushil Chawla, sir, for that excellent presentation. Now we move on to the next topic, that is literature search and referencing. For that we have Dr. A.G. Radhika Madam. For her introduction, she is a senior consultant OBGY, University College of Medical Science at GTB Hospital, Delhi. Her special interest and expertise, evidence-based healthcare guideline development. She has received many awards: ICOG Visiting Professor Award 2019, Foxy Korean Award 2019, Foxy Best Paper, third prize in 2016, WHO Fellow 2011 in Advanced Course on Monitoring and Evaluation in Health System, Expert Reviewer, Cochrane Collaboration, JOGI IJMR, JSAFOG, and she has publication, more than 75 publication in international and national journals, edited 2 books. With her long list of achievements, I would like to welcome Radhika Madam for her talk. Thank you.
Thank you so much, Gurpreet, for the kinds
Madam.
of, for introduction, for inviting me here. Thank you, the team Aurangabad Obs and Gynae Society for inviting me for the program. So the talk, my presentation today is literature search and reference management. Literature search, you see, we never used to talk about literature search, reference management about 10 or 15 years from today. The point is that today a lot of reading material is available, and because of the free access to the internet, there is a huge overload of information, and we don't know how credible which information is. And that is the reason that today there is a focus and there is thought about the importance of literature search. Are my slides visible?
Yes, madam.
Okay, so I'm just trying to get it on the slideshow. So what we as clinicians and the practicing doctors, what is our aim? So we aim to give the best to the patient, and we want that we also give the treatment as per the most recent evidence. Some problem is happening here. Okay. So it is important to provide the best practical medical care, meaning that we need to find the best evidence, applicability to the individual patient. So you have, you read a journal article, you read a systematic review, and you find that there is a certain treatment modality that is available. Now, whether that can be translated into practice is what is very important, meaning whether it can be applied to your patient, and is it practically possible to apply and extend that information onto treatment, considering the availability of resources as well as these surgical skills. So it is important to ask, acquire, appraise, and apply, and then again assess the impact of performance, meaning auditing. So we will just talk about this in some more detail in the next few slides. So what is evidence? It is the unbiased view of truth. So when you want to look for the best latest evidence, you want it to be as near the truth as possible, and that is totally unbiased. What is a bias? Bias is the difference between study results and the truth. And well-designed and well-executed studies help to get closer to this truth. Now, there are three components to the evidence-based healthcare. So there is the patient value, the best research evidence, and also the clinical expertise. So when all the three of them are joined together and the meeting point of all these three values is what is the evidence-based practice. So it is an integration of the best research evidence with clinical practice and the patient values. So the practice is formulating an clinical question followed by searching for the evidence, appraising the evidence that you get, incorporating that into the decision-making process, and then evaluating the process that has been already undertaken. So this is a cycle, and this one does throughout one's life. And this is especially, it can be applied for therapy, diagnosis, as well as for prognosis. So like I said, these are the 5 points: the ask, acquire, appraise, apply, and assess for the various evidence. So what is the importance of this evidence-based practice? It minimizes the clinical risk and the cost of treatment, optimizes the quality of health research, ensures a uniform standard of care. It is easy to audit the practice and helps to formulate good practice recommendations. So current scenario is that the physicians have a daily need for a lot of information for any of those three aspects. Traditional information sources are frequently out of date, incorrect, or overwhelming in their volume, and there could be a divergence in the clinical experience in the scientific study or knowledge which is present over a period of time, and there could be time constraints with very few less time available during the week or during the day for reading as well as the review. And that is why we need to understand the literature search and how to store that whatever you got, how to organize it in a easily accessible fashion so that you don't end up getting confused. So like I said, what the challenge is that there is such a lot of published literature that is available, and much of it is freely available not only to us but also to the patient. And so that is why we need to look and have the best the evidence that is available so that we are able to also explain to the patient. There is also, other than the published literature, we have a lot of unpublished reports, conference proceedings, and also the internet is full of information. This is also called the gray literature. And this is extremely important. There is something called the publication bias in publication, because there is a tendency for the journals not to publish negative reports, or there could be a language barrier, or there could be a number of other reasons why the literature doesn't get published. We all of us, especially in the low resource countries, face that. So, but they could be giving us something extremely important, and that is why this gray literature also needs to be looked into. So now we in India have the DELNet, which is a network of the libraries across the medical colleges in India, and it gives you an access to the thesis which has been done in the various institutions. So I would be also talking about that in the end of my talk. So now, what are the types of questions that one could have in mind? And do you necessarily have to access the internet for everything? So the answer is no. There could be background questions. These are general in nature and provide a foundational information on a single concept. And this essentially has two components. So the question root is when it is who, what, where, how, and why, and it addresses a disorder or some aspect of the disorder. For example, what are the drugs which are used for the treatment of hypertension, and what education resources exist for the mothers with gestational diabetes. So here, it is basically the root question is who, what, where, how, and why. So you don't really need to access the internet and go through all that rigmarole of finding out what is best that is available. These are well answered by the textbooks and also by some of these databases which have filtered information like up to date. Whereas the foreground questions are the ones which bring together multiple concepts related to a specific clinical situation or a research topic. Now, these could be of qualitative studies or this could be for quantitative studies. Majority of the studies that are undertaken by us are quantitative studies, though qualitative studies have also started coming up in India. Now, qualitative studies basically focus on a phenomenon. For example, an individual's experience, emotions, the social aspects of a certain situation. For instance, the pandemic, how it impacted the people mentally, and what was the experience like. There was a stoppage of the financial income, and that is why what was the reaction like. So those are kind of qualitative studies. Quantitative studies basically aim to discover the cause and effect relationship by comparing two or more individuals or groups based on differing outcomes or exposures or interventions, prognosis or therapy. So when there is when there are two aspects of a certain intervention or an outcome being compared, then the quantitative questions come up, and these are best answered by the resources which are found in the evidence pyramid. So what is the evidence pyramid? Now, this is the evidence pyramid. Now, it has got the, as you can find here, the editorials and the expert opinion, the case series at the bottom, and the systematic reviews, the randomized control trial. And here at the pinnacle, you have the guidelines which have been developed by any of these filtered, well-conducted systematic reviews, as well as the randomized control trials. So, for each of these levels, you have various resources from where you could gather that information. So from where and how you need to do that is actually the main point of my today's talk. So if you want to get something from here, we all want the best quality information. So how to access the systematic review or the clinical guidelines or the randomized control trials or the cohort studies is going to be what I'm going to show you. So the levels of evidence goes on changing with the change in the bias. So from below upwards, there is a reduction in the bias. There are about 7 types of bias in clinical research, starting from the selection, from the various aspects of methodology. So whether there was the selection criteria, the recruitment criteria, followed by whether there was equal what you had stated in your study, whether you actually were able to carry that out, followed by the calculation of the results, and finally the publication and the how the people have viewed your publication, where it has been published. So from below upwards, there is a reduction in the bias, and thereby the validity of the results of the study as well as the strength of inference goes on increasing from below upwards, and also the levels of evidence accordingly are also improved. They improve from below upwards. And that is why we need to know what is the best evidence and where to look for. So what is the criteria for selecting an information source? There has to be soundness of evidence-based approach. It has to be comprehensive and specific. There has to be an ease of use of that database or the book or whatever, and it has to be freely available. If it is going to cost you money, then again it becomes difficult. So there are basic six steps of literature search, and this is to define the topic, what you want to know. It has to be specific, it has to be clear, and then selection of the various resources, choosing of the keywords or the search terms, compile the search strategy and execute the search, review the results, and finally organize the results. So these are basically the 6 basic steps of literature search. So we start with step 1, which is to ask the right question. And that is the PICO and the PS. PICO is for quantitative study and PS is for, or SPIDER is for the qualitative study. So what is PICO? Patient, problem or population. I is the intervention. C is the comparison and O is the outcome. And for the qualitative study, P is the population and S is the situation, meaning the experience and all those examples that I gave. And here it also could be like, how do mothers with a detailed birth plan experience deviations from this plan? Or it could be spider, meaning sample, phenomenon of interest, design, evaluation, research type. So, why do we need to know all this? Why do we need to know about PICO and the PS acronyms? Because this is what is going to help us in the literature search. So, if you formulate a proper research question based on the PICO format, then searching the literature becomes extremely easy, as you will see in the next few slides. So, here is a case scenario: a 27-year-old mother presented for her initial prenatal visit at 10 weeks. The lab results showed mild anemia. Dietary history elicited showed that, it revealed that her diet was grossly deficient in the iron-rich foods. So, iron supplementation was discussed with the patient, and she expressed concern over the impact of on the health of the baby, meaning the iron supplementation, both the the drug as well as the diet. So, for a patient with iron deficiency anemia in early pregnancy, does iron supplementation increase the risk of adverse pregnancy outcomes? So, this is the clinical question as a clinician that we have. Now, we need to get this into the PICO format. Now, what are the possibilities? So, the population, or here the person is a 27-year-old lady with antenatal anemia. We want to compare iron supplementation without iron supplementation on the adverse pregnancy outcomes. Or it could even be foods along with the, you compare iron supplementation with dietary modification of the food and adverse pregnancy outcome. Or there could also be diet modification with no diet modification with improvement in the hemoglobin concentration, and iron supplementation with diet with improvement in the hemoglobin concentration. So this slide is specifically to show you that you need to have clear thoughts and clear PICO format ready for your literature search, otherwise the results are not specific, and then one gets into reading up too much literature and then you actually forget your initial question. So it is important for you to remember the PICO and the PS format. Now, where do we look for that information? So, like I said, it starts, this is the pyramid of evidence. Now, you have the filtered information where everything is available in one go. For example, Google Scholar, the expert, the Embase, PubMed has both the filtered as well as the unfiltered information. When I say unfiltered information, if one goes through the Google, it gives you the choice of opting for the relevance, or it can be up by the date. There are various ways by which you can see the results. However, these are not filtered. Nobody has critically appraised the literature. It is, what you see is what you get. It's simply that. Whereas the filtered format is where people have sat together, have done a critical appraisal of literature. Now, this could be in the form of compiled, write-ups as it is found in UpToDates, or it can be the Cochrane Library with systematic review, or it could be PubMed where the systematic review, the filtered as well as the unfiltered evidence is available. And there are other databases like TRIP database where you can choose what you want to look for. So my basic focus today is going to be also on the new PubMed, because in the last about 3-4 years, there has been a major change to the PubMed. And most of us are very, familiar with the PubMed, and we find it convenient to search in the PubMed. So there are a few tips and tricks which are important for us to learn to get the right answers. So this was launched in 2019. It has a clean, modern look, easy to use interface. It's an improved search engine designed to help and find the best match. And it has got a trusted citation data, and it is also available on the mobile app. There are new retrieval features, meaning better sensors for whatever the books, the words that are used, there could be change, there could be a difference in the spelling. The UK spelling could be different from the US spelling, and the pickup of the new PubMed is better, and there is also added synonymy. So when you have a single term, there could be synonyms to that term. Here, earlier what we had to do was to look for the synonym and then add them to the PubMed search. But today they already have the synonymy, incorporated into the software, and it includes that in the search. So, like I said, there is an improved British and American mapping, and there is unlimited truncation. So what is truncation is we will see just now. Scopus is also there. It is also another place where one can look for the necessary information. It covers a wider journal range, but it is, however, limited to the articles which have been published after 1995. And Google Scholar, it indexes scholarly literature like journals, academic books, conference papers, which is not available on PubMed or Scopus. And hence, it is very good for search of the gray literature, and especially material like conference papers that have not been published in the traditional ways. So PubMed uses standard terminology to facilitate searches using standardized terms, and it is freely accessible. So when I say standard terminology, what do I mean? It is called the mesh terms. So mesh terms is medical subject heading. So how is it important for us? So it's like any library, you know, where once there is a new book that comes in, the librarian catalogs it, you know, it is given a certain number, and depending on the subject that it belongs to and the subsection of that particular subject, it is catalogued and it is placed in the library. And so it is done also in the National Library of Medicine, which hosts the PubMed. And here there are there are medical subject headings, and based on the medical mesh terms, the manuscript is allocated its specific place and a specific PubMed number, PubMed ID, and that is how it is placed. So once you understand the mesh terms, how to access the mesh terms in case you are not able to get a specific answer, then it becomes much easier. Though the free text search is also available. So one could start with a free text search, and if the responses are not good enough, then you look for the mesh terms. Then the search strategy using Boolean operators and truncation, using certain filters like limits, abbreviations are to be better avoided. And when you search a term, PubMed will look for the records that contain the term in the bibliographic details and the abstract. So, and it does not read the full text. So, what do these two sentences mean for us? It is a double-edged information. The advantage is that once you publish a paper, you must try and include the main aspects, the filter of your work in the abstract, and also the bibliographic details, so that the number of eyeballs, the people who are searching for that particular literature, pick up your study, and that is how the citation of an author can improve. That is number one. Number two is your search terms have to be right enough, because you would not want to go through the entire full text to look for literature. So for you, the abstract is what is available for you to be able to easily access, finally go on to the full text. And that is why the use of the correct identification of the keywords is extremely important. So I have, in the last few slides talked about the Boolean operators. What are these Boolean operators? These are and, or, not. Okay, these three terms are called the Boolean operators. And by far, this basic principle of search applies not only to PubMed, it can be used in Google search, it can be used in Scopus, or in wherever you wish to look for literature. The basic principles of the use of Boolean operator as well as the truncation remains the same. So what is AND? AND is gives you the records which contains both the terms. For example, gestational diabetes and nutrition, probiotics and autism, high risk pregnancy and exercise. So when you want both these terms to be present, then you use AND. And mind you, capital. But now earlier it used to be very important to use a capital letter, but now PubMed allows you to even use the small ones. Or are the ones that contain the records that contain either one or more terms. So obese or overweight, neonate or newborn. So as you can find here, these are basically synonyms. So the two terms literally actually mean the same. So the records which contain either one or more terms, and there you use or, and not is when you want to exclude something. So the record excludes with a term that follows not. So human and not animal, newborn not preterm. So you want a term newborn only meaning. Okay. So use of these Boolean operators are very important. And then use of the quote marks. So for searching words which are together as a phrase and not as individual keywords, one could use the quote marks, for example, insulin resistance, and then the two words are looked together, are searched for together by the search engine. Then truncation. So truncation is the use of this asterisk at the end of a term to search for the same words with different endings. For example, nurse. So this could end as nurse, or it could be nurses, or it could be nursing, all at the same time. So when once you put NURS asterisk, so the search would find out publications which have words, all of these words which have been expressed sometime in the manuscript. So how do we apply this idea into PICO? So when you have a certain question in mind, so the basic principle is for PICO you combine P, I, and O with AND, because you want to have the patient, intervention, and outcome for search. So you include them as and when you put the population and you want a wider coverage of the population, you use or. So for each of these categories, the synonyms are joined together with or, and the stem of PICO is combined with and. So that is the basic principle of the literature search. So now let us see this video, and or what I'll do is I'll go to the video for the at the end of my talk, because I think it will take time to go over to the videos and then come back to it again, because it might interfere with the transmission. So I will complete my talk and then I would be showing two videos, one on literature search and second is on reference manager. So what is the incorrect search? It is a good idea not to use prepositions and conjunctions. These are the various stop words, and these are important that we remember that we don't use them. For example, prevalence of malaria and dengue in India, progress toward vaccines for dengue and malaria in children. So you try to reduce the number of words that are getting used in the search strategy to be able to arrive at the best results. So what are the databases that you can use to look for the best, to get the best results? So there are a huge number of, there is a big list, but these are some of the best databases that I very commonly use to access the literature, especially when I'm conducting a systematic review, because I need to get hold of all the literature that has been published on that particular subject, that is the research question of my systematic review. So these databases are specifically of use for systematic reviews as well as for randomized control trial. So this is the database of abstracts of review of effects, Cochrane database, Campbell library, PubMed, TRIP, Epistemonicas, Joanna Briggs Institute, UK database of uncertainties about the effects of treatments, Prospero, Medline, IndMed. This is what is available for India. Then you have the Embase, Sinal, Lilacs. So there is a long list there, and these are good databases to look for systematic review and the randomized control trials. These are few more areas, the URLs for the systematic review. The list was already given in the previous slide, and this is the link. Now, where are the good practice guidelines? These are of main use for us clinicians who don't want to just go on, looking at those databases. Those databases are specifically of use where people wish to conduct a systematic review, where you wish to access the maximum amount of literature. For example, if you're going for a debate or you're going to present a seminar, it is important for you to have a broad knowledge. If you just want to get a good clinical practice guideline, the suggested sites are GLOM. This is by the FIGO, and this is also freely available for people from India. Then you have the National Health Mission government publications of guideline. Then you have the Geneva Foundation for Medical Education and Research. This is also easily accessible for people from India, and these can be accessed for good clinical practice guidelines. So these are few areas from where the grey literature could also be accessed. So there is a dedicated website, in fact, from where the grey literature can be accessed. So how do you look for the best evidence? So you depends on the kind of study and your question that is getting asked. So there could be cost effectiveness studies, So because the earlier lecture had focused on the various types of study designs, so I just wanted to also bring this association between the research question and the kind of the study that you wish to look for. So there could be, prospective studies, blind comparison to a gold standard for diagnosis. There could be cohort and case control studies. Both of them are good for etiology as well as the prognosis. Quality of life studies for quality of life. Therapy, you have the systematic review as well as the randomized control trials. So these are the suggested types of studies that one could look for depending on the query that is getting asked. Now, briefly about systematic review, it is a summary of the medical literature, and it is done by there is a specific protocol. So once you understand the research question, it is like conducting a proper, research work. Here it is more on the academics. It is not a primary research, it is a secondary research. How is it a secondary research? Because you are actually collating all the primary studies that have been published on that subject, getting it all onto the table in one place, and finally collating those studies to bring out the filtered evidence of the robustness of that evidence and how it can be translated to practice. So, through explicit and reproducible methods, systematically searched literature which has been critically appraised and synthesized on a specific issue, and the results of multiple primary studies which are related to each other are synthesized by using strategies that reduce the biases as well as the random error. So it may or may not include the statistical synthesis. So you do a large literature review, and then you have the systematic review and then the meta-analysis. So when I say the literature review, this could be even a narrative review where there is nothing which has been given by way of the methodology. If I take up a narrative review and I just publish a paper on that as an expert opinion, if somebody else sitting in another corner of the world wants to replicate what I did, that is not possible because there is no transparency. Other person doesn't know how robust my search has been, whether what I am saying is really true, because whether those studies that I collected are unbiased, have been thoroughly searched for, and finally whether the filtered evidence is again without any kind of tilt in any direction. But systematic review is to a large extent, when properly conducted, removes all those bias, and when that is with a arithmetic translation of the results, it is called as meta-analysis. So the systematic reviews adhere to a strict scientific design based on explicit, pre-specified, and reproducible methods. So like I said, the systematic review passes through all these stages like one would conduct a primary research, whereas that is not the way a literature review goes through. And that is why today's systematic reviews are, the topmost type of the best quality evidence in the pyramid of evidence that I showed you earlier in the slides. Then we come to managing the references. So today, we have such a lot of work that is available. You collect such a lot of the information as well as the manuscripts. Now, when you really want to access them at any point of time, then it becomes extremely difficult. So now you have the reference management softwares which are available, and it demonstrates that you have conducted a thorough and appropriate literature search. Because today you could use these softwares and the bibliography which is obtained from these softwares to prove that you have actually done a thorough literature search, especially when it comes to guideline development as well as for systematic review. It allows the storing of articles, creation of full bibliographic reference in different formats, and they're integrated with word processors to facilitate citation in the reference list. So earlier it was all hard copies. Today you have the soft copies which can be read online, and these can be sent to the reference manager, and these are stored into the reference manager. So what are the various types of softwares which are available? The EndNote, the Mendeley, Zotero, reference work, and the BibTeX. Of these around 6 numbers, the ones which are popular are Mendeley and Zotero. EndNote actually costs money. The basic version is free, but it doesn't have a large space to store your matter. So Mendeley and Zotero are quite popular, and my favorite is Mendeley. So there is a comparison. This is basically which should you use. So you have the EndNote, Mendeley, and the Zotero. So this is free up to 300 MB open source and software. And then here the Mendeley has even more space that is available. It takes up so much of the space in your desktop, but the storage is also much more. And then it is free of cost, but then if you want to use the professional, then the cost increases. Again, here, these two are generally accessible, but here the cost is much more. And both these are available, which can be used, the language is English, and both can be used in any of the Windows programs. And this is also available in other languages. So I would be showing you the video again as to how to use these softwares. So Mendeley, you download Mendeley, and what you do is you also install the MS Word plugin so that you are able to use it as a referencing software when you are actually typing your manuscript. So same is the case with Zotero. You can use it as a Chrome extension, Firefox or Safari, and it comes onto the near the address bar, and then you can click on it and use it. So let's go to the videos of how to conduct the literature search. So it is a good idea to sign into the NCBI. Now they encourage a third-party sign-in option. I prefer to do that through the ORCID ID because it helps to interconnect all my publications with in the journals, and they are automatically synced into the PubMed. From here, I access the PubMed. Now let us take up a clinical query. I wish to understand how does carbetocin compare with oxytocin for the management of postpartum hemorrhage. So I want to see which is more effective, or what are the studies which are available for the control of postpartum hemorrhage, and how do the two drugs compare. So now it is important to see what is available on this page. The display options that are available, you can have a change in the format of the display option, or the sorting out could be by the best match, the most recent, the publication date. By default, it is best match now, as against relevance that was there earlier. And you can have the total number of results that can be displayed. You can change the numbers from 10 to over 200, and you can have the snippets showing on the presentation page. The total number of the citations which are there are 17, of which 14 are in English, and they are the ones which are displayed here. Now, now it is important to also understand how to use the filter. If I wish to reduce the total number of years, I wish to see only in the past around 6 years, because the older studies may not be of great relevance to me. So by that, the total number of results get reduced to 12. Now, the other options of the NCBI filters that are available are the text availability, which could be abstract, full text, or free full text, which is available. Then the associated data, then the various types of articles that can be there, and the publication date in the last 1 year, 5 years, 10 years in the custom range. Other than the filter that we applied here, that is the results by the year, the bar that can be shifted. You can also have it, the custom range applied here. And the sex here is postpartum hemorrhage, so it is only in the females. And then you can also have the additional filters. Now, these filters could be the article type, the species, language, the sex, the journal, as well as age. For instance, I want it only in the humans. Language, I prefer to have it in English language, then only in the females, and so on and so forth. So by applying these filters, you narrow down the results of your search. So the total number of results now with all those filters applied are 9, and the display is in one page only. So another important aspect to be also seen here is that other than uh, the total number of results that are there, which are relevant to my search items, I can choose the ones that I wish to also send the citation either to the clipboard or to my bibliography or to the collections, which requires NCBI sign-in, or to the citation manager. This could be any of the citation manager. One could create a file, or one could, select all the results which have been found here, and it could be sent to any of the citation managers that one is using. So now, for example, if I wish to have a look at this publication, it is also important to have a look at this page, because as you know, one can see that this shows the other 9 results. I can easily go into the 9 other results by using these arrows. And when I put my cursor there, it gives a brief uh, idea of what I'm going to see next, including the title of the next study. Now, it gives the full text links to this article, including the free full text where it can be accessed from. Then you have the citation. Here, the citation could be in various formats, starting from AMA to NLM. One could also copy it down, or one could download it to the external software. Then one could even add it to the favorites. To add it to the favorites, you need to sign into the NCBI. So it is important to also see that I have, also chosen my preference of display in the PubMed, and I wish to get my search terms highlighted in the green. So this is highlighted here. Uh, how to do that is outside the context of today's discussion. It is very simple. The NCBI and PubMed pages are very user friendly. Now, what is important and what I wish to highlight out of this page is that other than the fact that it gives the abstract as well as the the results and the conclusion, one could also see the similar articles that have been published in the recent past, and also what are the other studies which have cited the article that I have accessed just now, along with the cross references that are available. Then, what are the various publication types that are available, comparative study as well as the meta-analysis? And then you have the mesh terms. These mesh terms are extremely important to be looked at, especially if you want to conduct a search. Like, for instance, if one is undertaking a systematic review, a thorough literature search is extremely important. So one has to understand what are the mesh terms which are related to the current search. And then it also gives you the substances that have been looked at, the related information, and the other resources from where this information can be accessed from. So now let us have a brief look at also the advanced search button here. Now, one could also use these, once you go into that, it also gives you a look at what has been recently already done. So I just now used carbitocin versus oxytocin in the female from 2015 to 21. It has given the 9 results. And when I used only without, choosing the sex, as well as mm, the years remain the same. So the total number of search items are 12. So how to use these? I'll just give a brief demo of how it is done. So you type carbitocin here. Now you can also choose from the index. So carbitocin is 250. I add this and add with and then you want oxytocin. So I can again go into the index. This index again gives an idea of the mesh terms that are getting used. And then I can undertake a search. Here at present, I have not added hemorrhage. So the total number of results are 183. So now what the results have come up with are any of the articles which have carbitocin and oxytocin present in all the fields. So now I was also talking about the mesh term. So what are the mesh terms? That is the medical subject heading. And here is the database one could explore through the PubMed. Now, let us look at the oxytocin. Now, what is medical subject heading? It is basically the categorization of the key term of any publication and used for cataloging or assigning that publication to the library. So now here, when I type oxytocin and go into the mesh, this is the medical subject heading under which oxytocin has been categorized. Now the mesh also gives a brief idea of a brief introduction to what one is searching for. For instance, oxytocin is a non-peptide hormone released from the neurohypophysis. So it gives you a complete idea, a basic idea of what this oxytocin is about. So then one could use an external search to search the PubMed, or one goes into the oxytocin. Now, this is the mesh database for oxytocin. What I just wish to show you here are the subheadings that are available. One could use administration and dosage. This can go into the search builder, and this I can combine with and, or not. That means the Boolean items, and I can also decide on, for example, the pharmacokinetics. So I add it with and. I add and add pharmacokinetics. Right. So the oxytocin administration and dosage and the complete the search of this mesh term is now displayed in this page. Now, other than that, the mesh, there is a unique ID which is given to the mesh item here. And this is what I was wanting to draw your attention to. This is called as the mesh tree. So the oxytocin could either be categorized under the hormone, or it could be the amino acid or peptides. So when you look, one is searching for oxytocin, it could be as amino acid, as peptide, or it could be the hormone. So these mesh items, when you open up the entire mesh items, it is called as the exploding of the mesh items. So here it's a free download for Windows, and then you have reference manager for Mac as well as for Linux. And then when you go down, how to it also gives you a brief information as to how to use this software. And then also there is a Mendeley site which is available, which can be an add-in to the Microsoft Word, so that one is able to cite from the Mendeley library. Another important factor is that it can also be added as a Chrome extension. This is a Mendeley web importer, and this can be added as a Chrome extension, so that the documents can be directly downloaded into the library. Same is the case with Zotero. So one has the Zotero software, which can be also downloaded on the desktop, and the working of the two is almost similar. Now, this is the Google Scholar. So even Google Scholar can be added as a Chrome extension, or you can download the Google Scholar button. So let's go into the Google Scholar button, and then this can be added to Chrome. This I have already done here. And then this is the Chrome connector for Zotero. So this can easily be also added to the Google Chrome. Now, let's see how each works. The working is almost similar. A few points about the Mendeley first. Now, what is the advantage of adding it to the Google Chrome as an extension? Now, here I look for an article, for instance, this article. Now, I wish to download it to the Mendeley library. So, once I click on to the Mendeley extension, so the library opens up, and then I can decide where I wish to have my this PDF document placed. Now, another way of doing it is that one can take the DOI number. You can copy this DOI number, and then now let us go to the Mendeley. So I have the Mendeley desktop placed here as a quick access menu. So this is the library. So you have the various documents which are there. These are the categorization of the various publications that I have downloaded as per the study that I was doing. So you could even add. So I select the DOI number. I select this DOI number. I copy it and then go to the Mendeley library. And here I can add this manually. So I get down to the DOI, paste it here, and now I can look for this article online. So it gives me the URL as well as the abstract if it was published online, and this can be saved. So these are the various ways of how one could get around using the Mendeley desktop. Now let us go to the citation. For the citation manager, I go to this Word document. Now if I want to insert a citation here, I go to the references and then I use insert citation. Since I have Microsoft Office 365, so it comes as a separate icon here. Otherwise, normally it is present in the insert citation. It comes as a small box. So you could use the Mendeley site for inserting your citations from the library. So in case I wish to insert the citation here, I choose what I wish to cite, and I can choose the citation style. For example, if I want APA type of insertion of references, so I insert the two references. I can also change the citation style. For instance, if I want it to be changed to Vancouver, I can update the style. Then I go back to the references. Now I wish to, so the style on its own, it changes. Now supposing I wish to insert two more citations. So I go here and then I wish to insert the citations below the one which has been already done earlier. So what I need to do is I need to right click and come down and say, for instance, I insert one more reference. Then I come down further, enter below, and then use another insertion of citation. Now, having done that, now I wish to create a bibliography. And now I create a bibliography here. So it asks whether you would like the bibliography to be inserted at the cursor location. I write continue. So it inserts the bibliography here. So it becomes very easy to work around this way. So then you right click and exit out of this. Right, and then you can continue with your work. So this is how the citation manager works, not only for Mendeley but also for Zotero. Now let us go to see how Google Scholar works. So I have it already inserted as a Google extension. So I go here, I click the Google Scholar button, get it into full view. So now I wish to, for example, again go back to the same publication. So here it comes. If I wish to add this to my library, I will click on the stars here, right? And then I will add it to the library. I already have a label created as the iron deficiency anemia. I have added the 3 citations, 3 publications to the library. I go to my library and I'm able to access all the 3. Now, another advantage of the scholar is to be able to get the various styles of referencing. So these are the various styles, how the references can be. So you can simply select these and copy and paste it to your document. So you can copy from here and paste it to your document. And
Madam, sorry to interrupt you. How much time?
It's over. Yeah, it's
this
over.
Is oh, thank you, sir.
Yeah. So with that, I thank you for a patient hearing. So I think the last video ran a little too long, but it's it's a 2 days workshop, literature search and referencing. So I thought just by giving a talk, probably it is good idea to have a short video. So thank you so much. Thank you for inviting me, and I hope I could get across some bit of information. Kind of complicated, but then that is the way it is. Thank you.
Thank you so much, Radhika Madam. That was very elaborative and lucid presentation on the topic. Thank you so much. Now we move on to our next session. For that, I invite MOC for the program, Dr. Bhagyashri Ranjwan Madam. She is Assistant Lecturer, Institute of Medical Science and Research at Badnapur.
Dr. Kiranmai Devineni ma'am. Ma'am is Associate Professor at Usmania Medical College, Hyderabad, Telangana. Ma'am is Trainer of Trainers. Ma'am is Vice President and Secretary, Obstetrics Gynecological Society of Hyderabad, 2016-2019.
Thank you for making me part of this very prestigious and very important E-Picsep journal. The webinars. I have listened to a few of them and benefited also. So coming to the critical evaluation of a journal article, this was the topic given to me. So what is critical appraisal? By definition, application of, my bandwidth is little bit low. So application of rules of evidence to study the to a study to assess the validity of the data, completeness of reporting, methods and procedures, conclusions, compliance with ethical standards. And the rules of evidence vary with circumstances. Then there is another word, that is peer review. Many of us are peer reviewers for the Journal of Obstetrics and Gynaecology of India. The peer review means that manuscripts, when first received by the general editor, are sent out to be reviewed by several experts in the subject area of the manuscript. And the reviewer's task is to assess the manuscript critically for the quality of its science, its logic, the manner in which it is presented, and any other feature that might reflect on its value in the literature. Finally, peer review has served to greatly elevate the quality of literature. So a general survey, the following questions can be helpful. So is this topic of the paper appropriate for the journal, and is it an important or significant topic? Does the study add to the existing knowledge base? Does the title accurately reflect the content of the paper? Does the paper have a logical construction? Does the length of the paper need adjusting? Is it too long or too short? And the word limit. And then is the paper written in a clear and easily understandable style? And is the paper free of grammatical or typographical errors? Then comes the author details. Then the name and names of the authors, the corresponding, the first and second authors as per the guidelines, if they are present or not. And then the credentials, how the affiliations are given, the current position, past experience and area of expertise. And is the published material a departure from the author's specialty area? I mean, is there any mismatch? And then is the basic source of the knowledge presented the result of experience, subjective opinion, authority, or the scientific method? Then coming to the title of the article, does it indicate the topic and focus of the study? Does it indicate the research question? I mean, does it completely, explain or describe the research question? Is it meaningful and complete? Does it reflect the aim and objectives of the study? Does it give an idea about the design of the study? Does it look catchy, or is it very long or very short? So these are the few observations coming to the title. So when we come to the research hypothesis, it is a version of the research question which summarizes the main elements of the study, and it establishes the basis for tests of statistical significance. So the main elements are, it has sample, exposures and outcomes, and it is stated for analytical questions with comparison groups. And purely descriptive questions do not require hypothesis. So does the title, give a statement of the research hypothesis? And characteristics of good hypothesis are simple. It should be simple, specific, and stated in advance. So what is simple? Generally one exposure and one outcome. Specific, with no ambiguity about study participants or variables, and it is always stated in advance. That is written at outset and with focus on primary objective. Then coming to the abstract, what is an abstract? Abstract is an abbreviated, accurate representation of the contents of a document without added interpretation or criticism and without distinction as who wrote the abstract. It gives a brief summary of the article which usually appears at the head of the article. It is generally restricted to 200 to 300 words and gives a bird's eye view. So abstract can be informative abstract, which is generally a part of original research, original research articles with aims, objectives, methods, results, and conclusion. These are the parts of the abstract with around 100 to 250 words. And then the indicative abstract is used for long articles such as reviews, review of reviews, meta-analysis, etc. It gives general idea of the contents of the paper, but little, if any, idea of the specific methods and results. Then coming to the keywords, when you are evaluating the general article, the keywords are important for indexing and cataloging entries, and they facilitate the search from literature databases. The keywords selected should facilitate the data search engines when explore commands are given to the databases. Then you observe that whether this abstract is structured or unstructured, is it informative, indicative, or combination of both? Is it comprehensive in its contents? How long or short it is? Is it giving the gist of the whole text? And is there any mismatch in the information given in the abstract with what is present in the full text? Or does it contain any other information which is not in the text? These are your observations. Then coming to the introduction and conclusion are the two sections in any form of writing which are difficult to write, and also we have to get them right. So when you observe the introduction, it should ideally introduce the literature to the reader. It should provide a context and create a rationale for the current study. And it should have logically flowing sentences which create a movement from general, that is background, to specific. The structure has opening and a body and a termination, that which ends with the need for study or research question. So you observe whether the structure of introduction is correct or not, and then whether the introduction is meaningful, if it is built on existing literature, is it logically presented, are there omissions of some important studies in citations, or the citations followed with correct references in the given list of references, has it presented the need for the study, has it ended with presenting the need for the study, has it stated the research question or hypothesis. Then comes the methodology. So whether the methodology has the following subtopics: the target population, design of study and setting, then sampling frame, sample size, whether any blinding and randomization, the methods, and measurement strategies and calibration, then the statistical analysis and the ethical approval. So coming to the research design, is it appropriate for studying the research problem? Does the design control the extraneous variables? Does the design control for possible threats to internal and external validity? Is the control group truly equivalent to the experimental group except for the exposure to the experimental treatment? And what improvements could be made in the research design? Then the sample, is it representative of the population of interest? Is it adequate? Is there evidence of any sample error, or is there any evidence of sample bias? And coming to the methods and materials, Again, are they appropriate? Are they described in detail? Are they in accordance with the ethical standards for protection of animal and human subjects? What method was assigned to assign subjects to groups, and what method was used to assign treatment to the subjects? Then coming to the results, whether they are presented in the logical and comprehensive manner, or the important results presented in both tables and text matter, or the tables. You have already heard Dr. Chawla telling all the tables, figures and charts numbered properly. Are the tables showing descriptive, both descriptive and the analytical data? Are they simple or complicated? Do they match the text, or the results based on the aims and objectives of the study? Again, coming to the discussion, the next part is discussion. Is it meaningful? Does it highlight the important findings, the results of the study? Is there enough explanation of all significant findings? Is the comparison logical and reasoned properly? What are the limitations of the study, and are they presented in the discussion? Does the discussion open new vistas for further research? Then comes the summary and conclusion. The summary should provide a gist of what this study was all about, what was done and what was found. And then the reviewer it is important for the reviewer to arrive at their own conclusions after critically reading the paper, irrespective of the conclusions of the author. The reasoning proposed by the author in reaching conclusions should be rigorously analyzed and assessed for its strength. And finally, has the research question been answered, and have they generated and presented some new hypothesis as a conclusion? And coming to the references, there are two types of references. One is primary and the other is secondary references. Then are the references for every citation in the text part, tables, legends, etc. of the article, and how many secondary references are present? Are they accurate references? Are there enough references of recent publications, and have they been presented according to the specific scientific conventions, whatever the guidelines have required? Then comes the final test, that is the internal and external validity. Whether the study can be extrapolated to other populations and contexts, that is general population. Can the conclusions be applied to routine clinical practice? What is the utility of the population at large, that is what is the public health importance, and how significantly can it change our concepts, ideas and nature of practice, and what are its implications at the cost effectiveness or at the economic level? The validity, there are two types. One is internal. This is the critical appraisal skills application. This is only the methodological quality of the study. Whereas external validity is to see how true it is for wider population outside the study and the practical relevance. This I have taken from an article where they have anonymized the whole article and given a reviewer's report after critical evaluation of a paper. See, the reviewer can finally comment something like this after going through all the, every part of the general paper. Then comment on the topic, whether it is important and the outcome. Then the second para tells that the study design is poor and the lack of thorough literature review is there, and then it cannot be accepted. And then the suggestions that a review paper and not include any details of the retrospective study, and suggestion that unless they can address all the failings of their retrospective study, they do not seek to report it into a peer-reviewed journal. And final, the overall recommendation to the editor. Then the editor agrees with all the reviewers' comments, and the checklist is sent to the author with a covering email that encourages them to perform thorough literature reviews before embarking on future research. So this was an example of the critical review of a paper, which is not an exactly original, real paper, which was anonymized with all the details. So this is, I took up from the JOGI website, where they have given checklist for the reviewers, about 19, that is type of article, whether acceptable or not, title, author names, order, affiliated institute, and you have to check all this, each one of it. Abstract, whether structured or non-structured, the keywords, abbreviations, whether the word count is acceptable or not, tables with numbers, figures with captions, number, size, and references, the order of the first appearance, whether plagiarism check with Google or software, then language, then comment on grammar, then the scientific content, look for gross overall mistakes, then the ethics, ethical permissions, then the consent letter, invitation letter, letter of intents approval, and then the final decision with comments. And if you go to the JOGI website, there are clear guidelines how to, critically review an article. So the objective is to ensure that the manuscript uses past research and adds to existing literature. It is scientifically coherent, and these papers, once published, should be more read and more cited. So we have to remain unbiased and maintain confidentiality. We should be familiar with the format of the articles and also the instructions to the author, and also follow instructions for writing and submitting the review. It is desirable to look for similar publications on the same topic or publication or part of data elsewhere. I mean, reviewer has to provide comments to the corresponding author. And the paper structure, sample size, as I have already told, everything has to be seen. Every section of the manuscript has to be read carefully and commented upon specifically, and any missing analysis should be recorded and comment should be made for additional analysis and investigations. And discussion whether it should be connected to the data and result, and conclusion should justify the objective and references. So the comments are made with the recommendations, with all the points, with all the checklists. Then there is a word called, what the topic was given to me was critical, evaluation of a general article, which I think I have covered. The appraisal is something little different, where a published articles are evaluated or appraised to examine the research, to judge its trustworthiness, its value and relevance in a particular context. And it is an important element of the evidence-based medicine. So it is essential to combat information overload and to identify papers that are clinically relevant, and also for continuing professional development. It is a requirement for the evidence-based medicine component of many membership exams, and it's generally done for appraisal of published papers. So without critical appraisal, we see that the papers can have bias, which are submitted. Significant positive results are more likely to be published, that is publication bias, and English language finds a bias. Then published in a journal indexed in a literature database, especially in less developed countries, will have a database bias. And when they are cited by other authors, we can have a citation bias. And if the authors are published repeatedly, multiple publication bias. And such papers or research articles, if they are quoted by newspapers. So not go into this. So there are softwares like CASP and SIGN and CEBMH, which have checklists which are specific to particular study design. So for RCTs, the factors to look for are allocation, the randomization, stratification, and the confounders, and how blinding is done, and how the follow-up of participants is done, whether all the participants with the intention to treat without loss to follow-up are included, data collection, that is whether any bias is there, then the sample size, and then the presentation of results, etc. Then coming to the critical appraisal of systematic reviews, the factors to look for are literature search, that is, did it include published and unpublished materials as well as non-English language studies, and was personal contact with experts sought. Their quality control of studies is included, that is scoring system, whether used to rate studies, whether analysis is performed by at least 2 experts, then the homogeneity of the studies, presentation of results, and applicability to local population. Then with this, so this is my last slide. I think I hope I have not overshot my time, and thank you, Gurpreet, Dr. Gurpreet, for this opportunity.
Thank you, madam. That was very crisp and crystal clear presentation. Now we would invite Dr. Pradnya, madam, for her talk. Bhagyashri?
Dr. Pradnya Change, ma'am, is Associate Professor at Department of Obstetrics and Gynaecology, LP, MMC, and GH, Secretary and Manager, Journal of Obstetrics and Gynaecology of India, MUHS recognized postgraduate and undergraduate teacher, member of Youth Council of MOGS, published several articles in Index Journal. Welcome, ma'am.
Thank you so much for the kind introduction. At the outset, I would like to thank Aurangabad Society, the President, Secretary, for giving me this opportunity to present this important topic of evidence-based medicine. Today I'm going to speak on the important topic of evidence-based medicine. So this concept began during the year 1980s when this approach was first described to use scientific evidence to determine the best practice. This movement began early in England in the early 1990s. Evidence-based medicine or practice is the judicious use of the best current evidence in making decisions about the care of the individual patient. Evidence-based practice, it is an ideology as well as a method. The ideology springs from the ethical principle that clients deserve to be provided with the most effective interventions possible. And the method of finding out and then implementing those interventions is what is called as the evidence-based practice. David Sackett first defined evidence-based medicine as the integration of best research evidence with clinical expertise and patient values. So it is the explicit, judicious, and conscious use of current best evidence from medical care research to make decisions about the medical care of individuals. So evidence is something that furnishes proof or gives testimony or something that is legally submitted to ascertain the matter of truth. And hence evidence-based practice, it is a systematic interconnecting of scientifically generated evidence and tactic knowledge to the expert practitioner to achieve a change in the particular practice so that it benefits the patients better. What is the need? For making sure that each patient gets the best possible services so that the knowledge is updated and it is essential for lifelong learning. Also to provide good clinical judgment and improved care is provided so that many lives are saved. It provides the practicing doctor the best evidence to deliver effective care. It can help resolve problems in any clinical setting, achieve excellence, and reduce the variations in medical care. So it is the perfect integration. These three are the components of evidence-based medicine. The first is you find the best evidence. You also see what the patient values and what are the patient preferences. And on top of that, you use your clinical expertise also to decide what is the best for the patient. So what does the research say? Then the next patient is what does the patient want? What are they willing to do? And the third and the most important is also clinical knowledge is also to be taken into account is what does your experience tell and what has been the experience of your colleagues. So amalgamation of all the three aspects can help us to do evidence-based practice. So it is an integration of individual clinical expertise and also consider the best available external clinical evidence. So it has to be considered skills, judgment, you and your colleagues. Also what the research has to say. So you have to take conclusions from basic medical experiences, patient-centered clinical research, and also systematic research. What is not evidence-based medicine? It is not an expert opinion. It is not something that is in a textbooks. What the latest paper says, what is a traditional approach, what we have always been doing. Continuing medical education and choosing the most expensive treatment. The objective of evidence-based medicine is to improve the quality, provide patient satisfaction and reduce cost. So it encourages a dialogue between the patients and the providers. And patients are an equally important part in decision making. Patients feel that the doctors are listening to them and their opinion also holds true. Why is this evidence-based medicine important? Nowadays, lot of evidence is coming. Although evidence is needed on a daily basis, physicians don't get time to access it. The textbooks are sometimes out of date because they are written years back. By the time they are proofread and come in print, the knowledge is outdated and there is disorganization of the device. So what are the 5 steps that are required? First is you ask a clinical question. Then is you acquire the best evidence. Then you appraise the evidence. I think madam has already covered on how to appraise the evidence. You see whether it has been rightly done. Then if you're convinced, you apply the evidence and then assess your performance. So this is an ongoing cycle. You ask, you acquire, you appraise the evidence, then apply and then assess your performance. So asking means why are we practicing this way? Are we adhering to best practices? Can we produce? Then you acquire the best evidence. Level 1 evidence is that we have from RCTs. If we take the then it is free from bias and it should be introduced by the people themselves. So if you see, we have already understood what is the filtered and what is the unfiltered. So in the filtered, you have obviously the systematic reviews of these RCTs. They will always provide you with the best evidence. So these level of evidences are very important. So whenever a statement or a guideline is there, we should always check in the bracket it is written level 1A, level 2A. So what is this 1A? 1A is you have the systematic review of randomized control trials. 1B is individual RCTs, but they have a very narrow confidence interval. 2A is systematic review of cohort studies. 2B is individual cohort studies and low quality RCTs. 3A is systematic review of case control studies. 3B is case control studies. 4 is case series and poor quality cohort and case control studies. And at the bottom is the expert opinion. So as you can see, systematic review is the one which will obviously give us the best possible evidence. Then we appraise the evidence. We find what is good and bad. There is always a gray area which can never be defined as good or bad. So clinicians find it difficult. So always do critical appraisal as the steps taken in the previous lecture. Then we know whether it is safe, whether it is efficient, whether it is cost effective. Then we apply and then we assess the. So these are the same steps which are taken. So what are the quality or the features of a high quality evidence? You have a large number of subjects. The assignment to the groups is done randomly. They are double blinded. There is a placebo control, prospective. Then loss to follow up is less than 20. And the study which can be replicated across various and multiple centers. So if you see this hierarchy of evidence, you can see that the systematic reviews are at the apex. Lower down, you have the critically appraised topics, have the evidence synthesis, article synopsis, RCTs, cohort studies, case control, case series, and at the bottom is the expert opinion. As you can see, the information is either filtered or unfiltered. Filtered means somebody else is, the expert group is actually, they are reading out or they are trying to analyze the results of these studies, and unfiltered is where you yourself are going to acquire. So this hierarchy of evidence, you should always see the top, they always gives you the better results. So filtered resources is clinical experts and subject specialists. They pose a question and they synthesize evidence to state whether this conclusion is based on available research or not. These are very helpful because the large literature can be researched by them. Unfiltered are, if you go to Medline and search for some primary or secondary literature, there are clinical experiences and you also gather knowledge from patients, and also this data should be applicable to your local context, which is very important. So there are various models of doing evidence-based practice. One is the John Hopkins nursing model. You have practice, you have internal factors, culture, environment, staff, external factors, you have accreditation, legislation, and then the research can be experimental, quasi-experimental, or qualitative. The Iowa model, it focuses on organization and collaboration, and research is done. There is a star point in the model. So either it can be a knowledge-based trigger. So you can see these are the ways you start research because there is a problem or you want to acquire a knowledge. Then you see whether, it fits your organization. You assemble the research, you synthesize, critique this research. If you have sufficient evidence to do a pilot project, and then if the pilot project is successful, then you can go for a larger studies and then disseminate the results. And if no, then you can, change, you can implement these practices once you find that they are effective and monitor and analyze. So this is this A-star model of knowledge transmission. You discover, you summarize, you translate it into language which can be easily understood, integrate in your practice, and then evaluation is a continuous process that should go on. Then there is the Stetler model. This is also, it can be, instrumental and you can conceptualize. And it is used to create formal change within organization. So once an evidence comes, you should know how to implement it and use it on an informal basis in critical thinking. Then various problems and internal external factors have also to be considered before such a statement or a research element can be embedded in your practice. So lack of knowledge and skills should not inhibit the appropriate use of a new incoming modality of treatment. So if you are looking at cost factor, you use cost effectiveness studies. These give you the best evidence. For diagnosis, you have diagnostic validation studies. For etiology, cohort study is the best. For prognosis, again, a cohort study or a case control study. For quality of life, you have qualitative studies. And for a therapy, of course, the randomized control studies, which are, double blinded, they are always good. So you should always use an evidence-based approach. It should be comprehensive, specific, easy to use and available. So if you see the Cochrane library, you have all the filtered. So the Cochrane database or a DARE, it gives you filtered information. If you type a question, the group of experts have already done the research and they will tell you whether this type of treatment is valid or not. Then you have in between, you have clinical queries. You have filtered and the unfiltered. Unfiltered, you will yourself search on Google Scholar, PubMed, Embase. This will all be unfiltered. And then you have this databases, which can give you a perfect knowledge of. So the Apex is always the best. You go and what we have is summarize the evidence. So after you read the evidence, please see for yourself. Are these results valid? Was the study done correctly? Was the methodology correct? Is the study reproducible? What is the dropout rate? All these things, before you blindly follow a study, you have to consider. Are there any studies which are similar? Are there overall results? Can I apply this to my current patients? Are the important outcomes considered? Are there any drawbacks of the study? And so, as we see, systematic review will give you the answer to most of the questions. So you do systematic research, you critically appraise and synthesize the world literature on a specific issue. The most well-known is a Cochrane collaboration. Meta-analysis, it is a statistical technique. I think it has already been covered, and the results are mathematically combined to improve the reliability of the studies. So why it can be misleading? Sometimes even evidence can be misleading. You can have a publication bias, or you can have a statistical chance. You can be ghostwriters, or it can be invented. This is Archibald Cochrane. In 1979, he said, it is of great criticism to our profession. We have not organized a critical summary, and thus was born the Cochrane Review. Why the sudden interest? Because now we are realizing that therapy, prognosis, and there is consumer activism. So if you go by evidence, it is always beneficial for you as well as or your patients. What are the assumptions? So not evidence, all evidence is going to be equivalent. You have to follow the hierarchy of the study design. You have external evidence, but it can, individual clinical expertise is also equally important. And you start with the best external evidence. So what are the reasons it adds? It helps us, if you practice evidence-based medicine, you always have the current treatment. Okay, a primary physician needs to have access to the data, and hence they can accommodate all these evidence-based medicine into evidence-based practice. It improves transparency, and it is very important. There is accountability and there is value, and you have enough data, and it actually improves the patient care. And the final is it works. So if you, as you can see, the use of evidence-based medicine has resulted in quicker improvement, quicker recovery times. So as I said, you have to always consider the statistical chance, the publication bias, follow these pyramids of, holding the randomized control trial or the systematic review of the randomized control trial at the apex, and also study. If it is a rare, then obviously a single case or a case series will be guiding us. And depending on the problem, you see the appropriate study. And thus we can have the decision-making model, which is, we identify the problem, gather information, see all the alternatives which is available, weigh what is the evidence. After weighing the evidence, we choose, then we take action, and then we review the decision. We cannot just identify, take action. We cannot jump all these steps. We have to take each step at a time. So there is no success or failure. There is an opportunity for change. There is always an opportunity for better treatment. What are the benefits is, it minimizes the errors in patient care, reduces the cost of treatment, optimizes the quality, and skills learned in practicing are the same which are needed for being a lifelong self-directed learner. Also, if you have a habit of accessing literature on a daily basis, you can ensure advancement of knowledge. So unless we use a good evidence, we cannot give good care to the patients. There are algorithms, and clinical judgment also should be put to use when we follow these algorithms. Okay, so who benefits is the practitioners benefit, the researchers benefit, above all the patients, the community, and the policymakers. So this evidence should be put to use into practice and also into policy making. If it is not done, then all this research methodology or evidence-based medicine has no use. It has to be put into clinical knowledge. So right now the situations, we are drowning in information, but we are starved for knowledge. We have so much studies available, but you should have the time and also the expertise as to how this knowledge is to be assessed. So there is lack. So what are the barriers is lack of value. People don't know the importance. Difficulty in bringing out change at an organization, lack of administrative support, lack of knowledge, lack of time for research, lack of knowledge about research, complexity, and evidence-based medicine. What are the advantages is better information is provided, better patient outcome, increases confidence in decision making, guidelines can be formed, and healthcare professionals can provide high quality care. Disadvantages, it is time consuming. The client choice becomes reduced because if the evidence is not supporting a particular form of treatment, we will not offer it. It suppresses the creativity. Of course, it will influence the legal proceedings, because if a guideline says something and if you have not followed it, then you can be taken to task. Also, there is publication bias. Only the positive data is published. Negative data is not published. So you should also publish a negative data. And I would like to conclude that medicine is not an exact science, but it is a science of probability. The challenge to the physicians is to provide up-to-date medical care. The ultimate goal for us should be to provide our patient with lifelong, functional, satisfying, pain-free, symptom-free life. And we as in medical colleges have an important role to introduce this evidence-based medicine as a concept, as a philosophy, as a religion when our students do our thesis, because it is here where the seeds of research are sowed in the young students' mind. So it is evidence-based care is not a one-time thing. It's a lifelong approach to do clinical decision making and excel in practice. So it has to be backed by research findings, clinical expertise, patient values, and this research evidence is an expected standard form of practice, and the numerous barriers which should be overcome by gaining new knowledge and implementing this knowledge to improve patient care. And using the level of evidence, one can determine the strength of the research studies, assess the findings, and evaluate the evidence for potential implementation into best practices. So I encourage all the listeners to, these are my references, to do evidence-based practice and encourage research at their respective organizations.
Thank you, Dr. Pradnya ma'am, for excellent presentation. Now,
Thank you.
our next speaker is Dr. Preeti Verma ma'am.
Now, today my topic was basics of medical science. I am assistant professor in GMC Kannauj. Now, next, ma'am. Now, this is said by the famous statistician Lord Kelvin that when you can measure what you are speaking about and express it in numbers, you know something about. But when you cannot measure, when you cannot express it in number, your knowledge is of lack and an unsatisfactory kind. Next one. Now come to the definition of statics. The term statics itself denote, that means key this is the science and we are dealing with the numbers. And with the statics, what we have done, we collect the data, summarize and present it, and finally we analyze this data for getting some information. But the important thing is that this information which we are collecting should be unbiased. This is very important. Now next one. Now, what are the use of statics? This you should know. There are some important uses of statics. One is the descriptive information. Descriptive information means we want to take information either in the form of time, place, or person from any population. And second one is the prioritization of the problem. This is very important. Suppose we think that A or B disease is occurring in a community, but we don't know which disease is more prevalent. So this stat is used for the prioritization of the problem. Second one is the proof association between the different variables. And next one is the proof relation between the risk and diseases. This is also a very, very important use of biostatistics. Now compare new rates with the old one. The best example is that MMR, that means we take the maternal mortality rate. We always compare to what is the maternal mortality rate in the 2020 and what is in the 2001, so that we can say either it is increased or decreased. Now compare local result with the foreign ones. Now I have taken the example of COVID. We have compared the case fatality rate of our country with the foreign, and we say that the case fatality rate in our country regarding the COVID is less as compared to the America or other countries. Now next one is the for the evolution of the health program and the services. Now next please. Now this is the vicious cycle. We first we have collect the data, then finally we statistically analyze the data and we get the information. Further we, now that means this is the vicious cycle. Next one. Now come to the types of data. This slide is very important for the PG point of view. So because if a PG student don't know which type of data you are going to use, further when you are going to do your analysis in the SPSS, your analysis will be correctly wrong, because your SPSS asks which type of data are you going to use. So basically there are two types of data. One is the quantitative data and second one is the qualitative data. Quantitative terms itself, that means we are dealing with the numbers. Now this quantitative data is further divided into two. One is the discrete or second one is the continuous. And what is the basic difference between this discrete and continuous data? In the discrete data, the numbers are absolute. There is no fraction or there is no decimal. Suppose I am taking the example of number of patients. That means if we are going to do a study in a hospital, we can't say that I have taken 24.5 patients. We only say either we have to take 25 patients or the 26 patients. That means numbers are the absolute. Same thing the hospital beds or RBC count or etc. Now come to the continuous data. Continuous data, that means there is some fraction. Suppose, for example, as we have taken the hormone level. Hormone level, there are always giving a range. That means it may be 1.2, 1.3. So that means there is a chances of fraction. Now, second one is the most important data is the qualitative data. That means we are dealing with the qualitative. This qualitative data is of two types. One is the nominal and second one is the ordinal. Name itself denotes nominal means we are naming. Naming means either male or female, black or white, yes or no. That means we are naming. Now second one is the ordinal. Ordinal means we are giving an order. This is, suppose I have taken the example, grade of the tumor. We always grade. Yes, now this tumor is of first grade, second grade, first B or 2B. So now I think everybody will understood, because these types of data you should understand which type of data we are going use in our study. Now next slide. Now the presentation of data is it already covered, but we always present our data either in the form of tables or in the graphs. This is also depend upon the our data, which type of data we are using. The most important thing is that they must have title, self-explanatory, fully labeled and not the complicated. Because I have said this, because when we are going to present our oral presentation in the conferences, there is a limited time. So we should be so nobody has the time to read what you have written. They just only focus on their table and they ask, just tell me what are the important findings from your tables. So this is very important. Your table should be self-explanatory or not complicated. Now next. Now, before going to what is the confidence limit, confidence interval, I would like to describe this normal distribution curve, because further my topic will distribute around this. I think everybody know this is the normal distribution curve. All we know that this is the well-shaped curve, and this is bilateral symmetrical, or this is bilateral symmetrical. That is why here mean, median, or mode of all are coincide in the center. Now, second important thing we have studied in our UG, ki 1 plus minus standard deviation, it constitutes the area of 68.8%. What does it means? Ki if we have taken 1 plus minus SD, that means ki the area under the distribution curve is around 68.4. That means ki our the data result will lie within this limit, and the remaining will lie outside this our limit. That means ki we are expecting ki our maximum result should lie in this. Now, same thing, the 2 plus minus SD, that means ki this cover the area of normal distribution curve around 95%. This means ki we expect that our result will lie within this 95%. Now, next one. Now, what is the confidence interval? When we set up certain limits on both sides of the population mean on the basis of fact that the mean sample of the size are normally distribution around the population mean, this limit is called a confidence limit, and the range between the two is called a confidence interval. Next. Next. Now we can understood by this normal distribution curve. So I have already told, suppose these two lines are our the confidence limit, and the range which lies between this minimum or highest, this is called our confidence interval. Or generally we fix our confidence limit at the, we can fix at 95% level, or we can fix it 99% level, but generally we fix our this confidence limit at the 95%. That is why we have said that we are 95% confident that our data will lie within this acceptance zone. Now, next one. Now, what are the various statistical hypotheses? There are two type of hypothesis, all we know. One is the null hypothesis, or it is also called H naught, or second one is the alternative hypothesis, or this is called the H1. Now, what is null hypothesis? Null hypothesis, what it says? It says when we are doing a study, there was actually no difference between the two groups, or if a difference is agar it occur by only a chance, that means ki there is no difference. That is why it is also called a hypothesis of no difference. Now, on the opposite, what the alternate hypothesis says? Alternate hypothesis says that actually there is a difference between the two groups. That means ki these two hypotheses are opposite to each other. What null hypothesis? There is actually no difference. Alternate hypothesis, there is a difference. Now, next. Now, generally, we have heard the term two tail, one tail, left tail, right tail. Now, what is this? Now, this two tail, we said that the test is either two tail, one tail, or right tail. This is basically based upon our alternate hypothesis, because what our null hypothesis says, our null hypothesis says that there actually no difference. But according to the alternate hypothesis, there is actually a difference. अब when we are not clear कि जैसे suppose I am taking an example of two drug AV. So what alternate hypothesis said? Alternate hypothesis that there is actually a difference between drug A and B. But here we are not clear कि which drug is better than other. That means कि either A drug is better or the B drug is better. When we are not clear, then we can say that our test is the two tail. But further, when we further analyze and we said that our drug A is better than the drug B, then we can say that our test is left tail, and we say that the B drug is better than the A. That means ki we said that is our test is the right tail. That means ki this is the one tail test. Now next one. Now, what is the p-value? We always heard p-value, p-value, p-value. What is this p-value? This p-value, it may be defined as the probable chances of occurrence with which an event is expected to occur. Now, this term first given by the Carl Pearson is in his Pearson chi-square test. Now, next. Now, what is it means ki I have to ki what are the chances of occurrence? When we are doing a study, there is two chances of occurrence. Either we will lie in this area, or either we will lie outside this area. That means ki there is a both probability. Either we will lie in this, or we will lie in this area. Now, by this grid, this line denote our level of significance. Now we will fix our level of significance at this level. This is also called our significance level, or this is also called a critical level. And generally we fix our significance level at the level of 5%. What does it means? That means ki we are 95% confident that our result will lie this is zone, and only 5% chances that our result will lie outside this significant level, or at this level. If we done our study at this level, if our calculated value of test is less than the tabulated value, that means ki we are lying in this area. That means ki we are expecting the null hypothesis. But when our calculated value of any test is more than the tabulated value, then we will lie in this area. That means ki whatever study we have done, there is a significant difference. That means ki in this area we are going to reject a null hypothesis, or we are expecting the alternate hypothesis. Now next one. Now in most of the statistical study, the level of significance are set at either at the 5%, which I have already discussed, or in the 1%, or at the 0.5%. But generally we fix our level of significance at the 5%. That is why we have always say ki if p value is equal to less than 0.05, that means he is statistically significant. What it does mean? That means ki we are going to reject the alternative hypothesis, and we are going to accept the alternate hypothesis. If p value is equal to or more than 0.05, that means ki our study is statistically insignificant. We expect the alternate hypothesis, and we are going to reject the null alternate hypothesis. Now next. Now what is p-value interpretation? This line is very important. If the result are statistically significant, decide whether the observed difference are clinically important or not important. It is not always key if our p-value is equal to less than or that comes significant by the test, but you should always be clinically correlate ki either this significant value is important or not. Or if not significant, see if the sample size was adequate enough not to have missed a clinically important difference. Now next. Now come to the different types of error. In the context of testing or hypothesis, there are basically two types of error. One is the type 1 error, and second one is the type 2 error. Now next one. Now what is the type 1 error? This is the error of first kind. When it occurs when we are going to reject a null hypothesis when it is true. Or it is also called a type 1 error may be compared with so-called a false positive, or a type 1 error occur when we believe a falsehood, or it is denoted by a Greek word alpha. It usually equals to the significance level of test. Remember ki we fix type 1 error at the 5%, at 5%, which I have already discussed. This 5% generally taken as a significant level, or that if type 1 error is fixed by error, it means that there are about only 5 chances in 100 that we will reject the null hypothesis when it is a true. Now next, now what is the type 2 error? Type 2 error, also called a second type of error, or it type 2 occur, type 2 error means expecting the hypothesis which should have been rejected. In type 2 error, there may be compared, this is called a false negative. Now in type 2 error occur when one reject the alternate hypothesis, when the although the alternate hypothesis is true, and this is denoted by the beta. What is the power of study? Power of study, it is the ability to detect a statistically significant association, or the probability of finding a difference between groups if one truly exists, or the most important, probability of avoiding type 2 error, that is 1 minus beta. This is called our power of study. When we are going to avoid a type 2 error, this is called our power of study. What does it mean? I have in my previous slide I have said that key type 1 error we fixed at the level of 5%, that is also called a level of significance. Like that, we also fix our type 2 error at the 80%. This is fixed, we can't change anything. We fix this error at the 80%. What does it means? It means a study that has less than 80% ability to detect a false alternate hypothesis is no expect or probable. Or second one is the probability of doing type 2 error is 20 times in the 100 trial. That means if we are going to do 100 trial, if we do a if there is the error in the 20 trial, that is expect, that is expecting. Now next one, what are the factors affecting the power? These all, as the sample size increases, our power is also increases. As population variance decreases, power increases. As the difference increases, power also increases. Statistical power is greater for one tail test, and the greater the probability of making a type 1 error, greater is the power. Now next one. Now this slide I have taken ki you should know ki what is the how will you find our study sample. From this we can say that ki if we are going to do a study, we will take a population. We will decide that ki I will take my population from this area. From this population, on the basis of clinical and demographic profile, we will finally select a target population. That means ki in this area, this is my target population. On the basis of geographical and temporal, we will select our accessible population, and from this accessible population, we will finally found our study sample. Now next one. Now, what is the selection criteria? For the selection criteria, when we want to take our accessible population, we will find our this accessible population on the basis of inclusion criteria, which you should have to prior decide in our study ki whose subject are included in my study. Or finally, when we are want to get our study population, this study population we will find on the basis of exclusion criteria, which we should be already decide. Now next. Now come to the sampling. This is also a very important part of medical biostatics. As we know, there are two types of sampling. One is the probable sampling, second one is the non-probable probable sampling. What is the probable sampling? Probable sampling means ki all the units have equal chances of being selected. Now, what is the non-probable bias? That means ki all the units have not equal chance of being selected. This is the major difference between this probable and the non-probable sampling. Now, next one. Now, what are the various type of probable sampling? Now, first is the simple random sampling. We have many times here, I have done simple random sampling. So now what is the simple random? In which population we are going to do this simple random sampling? We will done this simple random sampling in a small, homogeneous and a readily available population. And there are basically two methods for doing a random sampling use. One is the lottery method and second one is the random number table. Now, second sampling, probable sampling, is the systematic random sampling. This systematic random sampling is done in a large. Second one is the homogeneous. And the next important requirement for this sampling is a complete list of population must be available. Or for doing this systematic sample randoming, we should know what is the sample interval. Now, how we will calculate this simple interval? This simple interval will be calculated by the total population upon the desired sample size. That is why I have told a complete list of population should be available for the systematic random sampling. Otherwise, we will not able to calculate our sample random sample interval. Now, suppose I am taking an example that the total population, if I want to do a survey and the total population of that survey area is 1000, and my desire, I want to take 100 subjects from that population. That means my desired sample size is 100. Now, what is the my simple interval came? It is 1000 upon 100. That means it came to 10. So after when I will get my sample interval, then what my further step? Now then I will take a 10 cards that I have number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and I randomly pull a card. Suppose I have picked up a 6 number card. So then my first unit of study is the 6th number. Then second one is my study of unit. Then I will add 6 plus 10. That means 16. Now further what is my unit of study? That means 16 plus 10. That means every time you should add this 10 sample interval. Next. Now, what is the stratified random sampling? Stratified itself denote that we will. It means it is done when our population is not homogeneous. That means not equal. In this per population first divided into the homogeneous group, and the sample is drawn from each strata at random in proportional to its size. That means what do we mean this? That means first we will first the heterogeneous population, then we will convert this heterogeneous population into homogeneous. That means it constitute our strata. Or the important thing we should always take our sample size from the each strata. Now, second one is the multi-stage. Multi-stage name itself denote sampling procedure carry out in the several stages using random sampling technique. Now, what is the cluster sampling? Cluster sampling is study area. First, we should divide the study area into the small cluster, and we will collect data from these clusters. Now, multi-phase sampling, that means the part of information is collected from the whole population and the part of from the subsample. Next. Now, these are the some example of non-probability sampling. One is the quota sampling, purposes of judgmental sampling, convenience and availability sampling, snowball sampling, and voluntary sampling. Generally, in a PG, generally we are not using this non-probability sampling. So I will not go in the detail of this non-probability sampling. Now, next one. Now come to the most important part of my presentation, sample size calculation. This is when I was doing my PG, I was also so worried ki what is the sample size of my study, what is the sample size of my study. So for the PG student, this is very important. Before I'm going to my next slide, first, what are the various steps? First, you should identify major study variables. Next one is the determine type of estimate. Next one is the indicate expected frequency of factor of interest. Second one is the decide on desired precision of the estimate. Decide on acceptable risk that estimate will fall outside its real population value. Adjust for the population size. Now next. Now this is the formula when we are want to calculate a sample size for a population mean. That means कि for the quantitative data, this formula is this formula is inbuilt. We want only put a value in this formula. Now remember कि this formula is for the sample size required for estimating the population mean. That means कि this formula is used when we want our sample size for mean. Now what is this? This is the n z squared, sigma square, and a d square. Now what is this z square? Z square is the Z score, its value at the 95% confidence limit or at the level of 5% significant. This value is fixed. Matlab we have to take this value 1.9. Now D, what is the D? D is the desirable error. Now next, I will give the example for the calculating the sample size for the population mean. Suppose कि a health department nutritionist wishing to conduct a survey among a population of teenage girls to determine the average daily protein intake. That means कि he want to calculate कि what is the average daily intake for the teenage girl of the protein. Now, what information is needed to estimate the sample size? One, the nutritionist must provide 3 items. One is the desired width of the confidence interval, the level of confidence desired, and the magnitude of the population variance. Now next. Now the solution. The nutritionist would like an interval about 10 units wide. 10 units wide, what does it mean? That means the estimate should be within about 5 units of true value. This 5 units of true value, they constitute our desirable error or the allowable error. That now our confidence, that means this nutritionist fixed at it 95% confidence limit and from the past experience, and the nutritionist feel that the population standard deviation was about 20 grams, and he has taken this from the previous study. Now we will have the value of Z, which is I have already told ki this is fixed. It is 1.96. Now what is this standard deviation? It is 2. Or what is D? That means ki the nutritionist wants the 5 unit desirable. That means ki 5 unit plus 5 unit minus. When we will put all these value, after the calculation, our result with this is 61. That means ki this nutritionist want to take the sample size came to 62. Now next. Now second step, sample size required for estimating a proportion or the prevalence. This is the most commonly used formula for calculating of the sample size. Remember, this is for the qualitative data. That means if we are going to study a proportion or a prevalence. This what is N? This is Z square or PQ upon D square. What is the P? This P is the proportion or the prevalence. What is the Q? This Q is 1 minus P. Now, what is the D? I have already told this is the desirable error or the allowable error. Now the Z, now the value of Z, which I have already told, okay, this is fixed. Or when I was doing a PG, this formula is in many textbook is also written as 4PQ upon D square or L square. This is the same when this Z square, this is when we take it 1.96, or otherwise you can roughly you can take it as a 2. When we will do a square of 2, that means it comes 4. That means it is a 4PQ upon D square or a L square. Now next. Now the example I want to estimate the true immunization coverage in a community of a school. The previous study tell us that the immunization coverage should be somewhat around 28%. That means that from the previous study, I found that the prevalence or proportion of this immunization coverage was the 80%. This is my P. Or precision, I would decide this precision at the 4% precision or the allowable level. The most important thing which you should remember ki if this precision or allowable error is not given, then this is generally we will fix this at the level of at 5% or the 4%. And the next most important thing is that key this 4%, this 4% is of this 80%, because because in this problem it is already given. If I have not given in this problem, then I will take it generally as a 5%. And the confidence level convention 9% or Z alpha. Now from this, what are the my value? My value D, absolute precision or my allowable error is 4%. This come to 0.04. Now what is the P? This is our my P, that is 0.8%. This the value of Z, which I have already told, this is the fixed. Now next one. Now, when I put all these values, Z 1.96 square, P is my 8.8%, 1 minus P came to my 0.2%, and my D or allowable error is 0.0%. Now the my sample size is came to 384. This is the my sample size for the calculation of proportion or the prevalence. Now next. Now the sample size calculation in comparison to group. When we are going to a study when there are two comparison group, then we will apply this formula. This is very simple formula, and for each group one is what is it P0 Q0 plus P1 Q1, then Z1 minus alpha by 2 plus Z1 minus 2 beta ka square, then P1 minus P0 ka whole square. Now what is this P0? P0 is the prevalence or proportion in a non-diseased person. What is the Q? I have already told previously. What is this Q1 minus P? What is the P1? This is the proportion or prevalence in a diseased person. What is the Q? This is the 1 minus P1. Z alpha, the value of Z alpha, I have already told the value of Z alpha. Generally, we take at 95% confidence limit, that is 1.96. Now the value of Z 1 minus beta, this is, remember, this is our type 1 error, this is our type 2 error. So this 1 minus beta, I have already discussed in my previous lecture, we will fix it at a 80%. Now next one. Now I have taken the example for this calculation. The cohort study of oral contraceptive use in relation to the risk MI among women of childbearing age. From the previous study, it was found that the proportion of non-contraceptive users who are at risk of disease was 0.1%. Proportion of oral OC users who are risk of disease is 0.5%. Conventional alpha, which I have already told, is we fixed at the 5% level, and what conventional beta at the 80%. This we fixed at the 0.2%. That means this value is fixed. Now next one. Now Now P proportion, now one P proportion of the non-user from the previous slide, it is 1.5. Proportion of contraceptive user who are diseased, 0.25. How will I calculate Q1? 1 minus P, that came to 0.8. Now what is Q1? 1 minus 0.25, that is 0.75. The value of alpha, this is fixed. Now the value of 1 minus, it is 0.84 at the 80%. Now next. When I put all these value in this, then my sample size came to 2486.96. That means I have to take 247 cases in the each group, either a case or in the control. Next. Now these are the various free software which are available for the calculation of the sample size. www.openep.com, PS power and sample size calculation by the Department of Biostatics, Vanderbilt University, and this G power. I commonly use this G power. This is very useful for the calculation of the sample size. Now next one. Now next one, for testing of our hypothesis, that means we are going to apply a test. Before going to what are the various type of tests we should apply, we should do these steps. These steps are very important. What first step is defining the research question. The research question means you should be very clear what is your objective, or the objective are of two types. One is the primary objective, or second one is the secondary objective. So our further slide will based on our this primary object. Now second our step, you should fix the null hypothesis. What null hypothesis says? Ki there is no difference between the groups. And what next is step? You should decide the alternate hypothesis. What alternate hypothesis said ki there is a actually difference. Now further this test criteria will be focused on either this hypothesis is true or either this hypothesis is true. Now second one is the selecting appropriate test. Second one is the calculation of the test criteria, deciding the acceptable level of significance, which I have already told you, we generally fix this at the 5%. Now compare the test criteria with the theoretical value. That means when we compare our calculated value of test with the tabulated value, and finally we'll inference or conclude either which type of hypothesis is true. Now next one. Now test, what is the importance of test of significance? That test which is done for testing the research hypothesis and is the null hypothesis. Why it is done? To assist administrator or clinician in making decision. The difference is real or it happened by chance. Next. Now when we will rejecting, and this is also important. This thing I have already discussed in my previous slide. When we will rejecting a null hypothesis, difference is significant. When we accepting the null hypothesis, difference is not significant. Now next. Now for testing of hypothesis, there are two types of test. One is called a parametric test. Second one is called a non-parametric test. This is important. Where we done a parametric test, we done these parametric test on a quantitative data. In my previous slide, that is, I have focused that the PG student or student should know which type of data they are going to use, because all their analysis will depend on the type of data. Now non-parametric, this is done on the qualitative data. Next one is this parametric test must follow the normal distribution curve. These non-parametric not follow the normal distribution curve. Second one is the prerequisite for the parametric test. The sample must be randomly drawn. And for the non-parametric, the data for these tests are frequency. Now next one. Now these are the examples of parametric and non-parametric tests. Generally, in our medical field, the parametric tests which we commonly use are the JET test, T test, or ANOVA test. Where we apply the parametric test, I have already told that we will apply these parametric tests in a quantitative data. And now, what is the JET test? Where we apply this JET test? This JET test we apply when our population is large. What do we mean understand by this large population? That means when our sample size is more than 30, then we are going to apply this JET test. For remember these parametric tests, these are also for the significance in difference in the difference in the mean. That means when we calculate a means of either a single sample or a two sample, we want to know is there any significant difference occur or not. Then we will use this parametric test or JET test. JET test, this is applied for the large sample size. That means when our sample size is more than 30. Now come to the T test. This student T test, this is of two types. One is the paired student test, or second one is the unpaired. What is the paired? When we use a single dependent samples, then this is the paired test. Generally, we say before or after. Now, second one is the unpaired. Unpaired when there is a two dependent sample size. Now, what is next one parametric test? This is the ANOVA. ANOVA means analysis of variance. Where we use this ANOVA when we want to compare the means of more than two groups. That means when we have the three groups and we want to compare the means of these three groups, then we will use this ANOVA. Now, second is the non-parametric test, which is used for the qualitative test data, and the most commonly we use this chi-square test. Everybody was here chi-square test. Remember this chi-square test most commonly used for the qualitative data. That is why it is a non-parametric test. Now next. Now, this is further for the parametric test. Now, suppose parametric test when it is a one sample. So, what test we can use? We can either use a paired T test or a JET test. When this parametric test, when we have a two sample depend on either they are independent sample or they are dependent on the paired sample. When they are independent sample, then we are going to use, when the sample size is less than 30, then we will use two group T test. When the sample size is more than 30, then we will use this JET test. And when the two samples are paired, so we will always use this paired T test. Now next. Now, what are the prerequisites or assumption for doing a T test? That means what should you require? The one is the sample size must be randomly selected, used for the quantitative data. I am repeating this again and again. Variable follow normal distribution sufficiently large size. That means we will apply a JET test when our sample size is more than 30 for a parametric test or for the qualitative. Next. Now for the T test, the parent population from which the sample is drawn is normal. The sample observation are independent, and the sample is random. The population standard deviation is unknown. Now next. Now for the prerequisite of unpaired T test, sample size, I have already told the sample is when it is used and the sample size is small. The population variance or standard deviation for this T test is not known. Two separate group of sample drawn from two separate population. These two groups can be control of cases. Pair tests apply only when the individual gives a pair of data. That means the study of accuracy of instrument or study on the weight of individual on two different. That means before or after. Next. Now, chi-square test. What are the prerequisites for these tests? This is used for the qualitative test. Now the sample must be randomly selected. or none of the observed value must be 0. This is very important. And adequate cell size. That means ki if this number is 0, that means ki the chi-square test will not give a right result. So this is very important. None of the observed value should not be 0, or adequate sample size, adequate cell size. That means ki the cell size should be minimum. If this cell size is less than 5, then the test of goodness of fit is applied. Now next. Now the final conclusion. This is important. Ki when which type of test you are going to apply, if our calculated value is less than tabulated value at 5% significant level, then the p value, our p value comes to more than 0.05. That means we are going to accept the null hypothesis. And but if our calculated value is more than tabulated value at 5%, then our p will come less than 0.05. That means we are going to accept the alternate hypothesis. Remember this n-1 or degree of freedom, this degree of freedom is different for every test, and these tabulated value, the tables are given. When we finally calculate this degree of freedom, then we will go to our tabulated table. Then we will see suppose at the degree of freedom 23, our tabulated value is this. Then we will compare our calculated value with the tabulated value, and that time we will decide if our p value is either it is less than 0.05% or more than 0.05%.
Thank you, Dr. Preeti ma'am, for excellent presentation.
Thank you.
Now,
Bhagyashri, we have got Dr. Geetha Balsarkar madam. She has logged in. She was traveling and now I think she has landed, and she has logged in immediately after landing, and she's here for the presentation. I've requested Ashwini madam to will have her talk first. To introduce Dr. Geetha Balsarkar madam, she has done MBBS, MD Obstetrics and Gynae, DGO, DNB, FCPS, Obs and Gynae, Editor-in-Chief, Journal of Obstetrics and Gynaecology of India, Foxy Journal, Librarian of Mumbai Obstetrics and Gynaecology Society 2021, President, Association of Medical Women in India, Mumbai branch 2019, President, Menopause Society, Mumbai branch 2021, Chairperson of Young Talent Committee, Foxy 2014, recipient of the prestigious Har Gobind Foundation for the Study of Fetal Medicine in 2008 at St. George's Hospital, London, Professor St. G.S. Medical College and Nauroji Wadia Maternity Hospital, have undergone training for the PPIUCD program, and is also the faculty member of many training programs as well. With her long list of achievements, I welcome you, madam.
And I welcome you all for this very important topic. Actually, it is the selection of topic for research, and it is among the first topics that are normally taken in a Picsep program. Now, the selection of topic for research is a challenge, not only for the students, but also for all the professionals. We have to remember that it is a very big task to think about what we want to do research, or what should be our topic of research. It is really important to do the right research as well as to do the research right. You need to do wow research that is compelling and not just interesting. It has to be interesting for you as well as interesting for the reader also. George Springer is who said this. He is the chairman of aeronautics and the astronautics department of Stanford University. And today it is a Springer which prints and publishes our journal. The JOGI journal is printed and published by Springer. Therefore, we have to remember that the research has to be right and we have to do the correct research. And therefore, from perspective, I will start talking. A topic is something that is different from a subject, although these terms are used interchangeably. To avoid any confusion, let's recall that in high school we studied different subjects. Physics was a subject, whereas Newton's law of motion was a topic. Obstetrics and gynecology is a subject, whereas anything about labor is a topic. So we have to know what is a subject and what is a topic. A subject of research refers to the broad and general contents, whereas a topic of research is a specific issue which is being investigated. Now, what is the role of the guide? Funded research project, then the candidate is supposed to work on the already identified topics and objectives. Therefore, there is not much scope for thinking about what do a research do I do. You just have to fit into whatever has already been told to you. The guide may suggest some research topics which will be already an extension of his her prior research. The guide may have knowledge in the topic and the researcher also can get support from him. Therefore, it is very supervisor. There is a different role of supervisor and there is a different role of the student. There is a different role of the supervisor and there is a different role of the student. But the role of the supervisor is to assist the student in identifying a suitable research topic to see what the student is particularly interested. Then they monitor the students' progress from time to time, guide students what to do and explain the reason behind it, why they are supposed to do a particular thing, and to assist the student in the interpretation of the research finding and make students aware of their responsibilities and supervisors' expectations. Consult and advise when the student has a personal problem, and the role of the student is to listen to what the guide is telling and to choose the research topic with the help of the supervisor. If they choose some other research topic which is out of scope of the supervisor, then the supervisor may not be able to help them. To work systematically and within the agreed deadlines as far as possible in order to meet the program deadlines, and to be well prepared for meetings with the supervisor, to give serious attention to what the supervisor is saying, and especially when they go for a meeting with the supervisor, they have to come very well prepared to realize that the supervisor also has other duties and commitments, and to perform research as per a supervisor's directions. To generate ideas for potential research topic, where do we get the ideas? Creative thinking is needed to generate new, original and unique ideas. Literature review to determine what is known and what is not known, and the areas that need additional research. We carefully look through recommendations for future research and limitation sections of dissertations and review articles published in the scholarly journals. If we can search on the internet, but we must be careful that not every website is trustworthy and secure. We have to avoid the non-trustworthy websites. We can attend presentations, discussions and recommendations of conferences, seminars in the field to get ideas about the current and the future research needs. The participant can approach the authors also for their suggestions as they can further research in that particular field. Now what? The researcher can interact with fellow students, other seniors in the department and teachers who can stimulate and give innovative ideas. A good research may arise from certain conditions or situations in the world, like the present situation due to COVID-19 has created various opportunities for research. And we at the Journal of Obstetrics and Gynaecology of India, we have come with a supplementary COVID issue. That means entire issue is about the articles on COVID research. So that is a very good topic which has been generated. Now, if you see this particular, type of chart, the level of students involvement versus the level of supervisors involvement. In the topmost is the first quadrant, where there is a high level of students involvement and a high level of supervisors involvement. Whereas if the second quadrant is what we see, the second and the third one is what we see. The second quadrant is the level of the students involvement is high, but the level of the supervisors involvement is low. The supervisor may have more than one student. They may be pressed with their clinical duties. Then normally what we see is also apprenticeship. That is, the level of the student involvement is low, whereas the level of the supervisor involvement is very high. And the quadrant 4 is totally unadvisable, where the level of the student involvement is also poor and the supervisor's involvement is also poor. When we think about a topic for research, remember the mnemonic friends. F is feasible, R for relevant, I for interesting, E for ethical, N for narrow, D for discipline, and S for supervisor. F is feasible, the manpower has to be feasible, the time frame 3 months, 6 months, 1 year has to be feasible, it has to be financial, equipment, software, everything has to be available. R is relevant, it has to be scientifically relevant, practically relevant, social and personally relevant. It has to be very interesting. The student has to be motivated. They have to have passion and curiosity. E is ethical. Human and animals code of ethics. N is narrow, neither too broad nor too narrow, and focused and specific. D is discipline. There has to be a core discipline, other related disciplines, specifications and standards. And S stands for the supervisor. The supervisor should have the knowledge, the interest, the involvement, commitment, and honesty. So what is the criteria for a good research topic? That is feasible, significant to the discipline. There has to be originality, peer support, and availability of subjects. The researcher's competence has to be seen. The topic has to be very current as to what is happening around the world. It has to be interesting for the readers to read. It has to be very clear and unambiguous. It has to be relevant, systematic, and we have to look into the ethics as well. Good research topic is choose a topic that interests you. Ensure that the topic is relevant. Keep the topic very focused. Don't take a very broad topic, and ensure that you have enough resources to support your research. So what are the sources for research idea? We can search the medical literature. We can search the scientific literature. There are many journals which are open access journals. These open access journals, you can download all the articles for free. You can look through these open access journals for great ideas. Then there is Health Internetwork Access to Research Initiative, HINARI. Then there is WHO Regional Health Sciences Library, which gives us all the guidelines and everything pertaining to our specialty. Then there is Medicus Index. There is PubMed Central. All the JOGI articles are also available free on PubMed Central after 1 year. Then there is Cochrane collaboration. There is Index Copernicus. So we have a lot of ways in which we can find out the research article. 6 ways to find a topic. First is a flash of brilliance model. You wake up one day with a new insight or an idea, new approach to solve an important problem, but this rarely happens. And even if it does, you will not be able to find a guide or an advisor who agrees to supervise you. Then the apprentice model, which is most of the times we see, advisor gives you a list of topic, suggest one or more that you can work on. This will save a lot of time and anxiety. But remember, you have to be genuinely interested in what the supervisor is telling you. If you are not, you please change your supervisor. And several students may be working on the same or the related problem. Then is a Phoenix model. You work on some subjects and think very hard about what you have done, looking for insights, re-implement it in a common framework, identify an algorithm or proof. The topic emerges from your work. It's especially common. From one thesis, you make 4 papers. This is the Phoenix model. You may be working on the topic for a very long time and try to take out small papers from a thesis that is already written. Then is a stapler model. You work on a number of small topics that turn into a series of conference papers, and somehow you tie it all together, create a chapter and put a big staple through it. But it may be very hard or impossible to find the tie. The synthesis model, you read some papers from other subfields and other subjects like computer science or anything others, and look for places to apply insight from other fields to your own. But then this can take a lot of time and you may not find useful connections. Then the expanded term project, you take the project course that gives a new perspective. This project of papers combine your research project and the course project. This can distract from your research if you cannot find a related project or a paper. Then remember, don't be afraid to take risk. Switching areas and advisors can be risky. You may move out of your advisors. You don't know what the related work, you're starting from scratch, but it can be very refreshing. And remember, it's very, very hard to publish negative results. So what are the phases of research project? First is thinking, identifying the problem and purpose of the purpose, review of literature. Then is the planning, choosing the study, design, planning, approach to the sample, data collection, etc. Then comes implementing, recruiting participants and collecting data. Then is analyzing, and last is informing, wherein you publish in the journal articles and presentations. So what are the steps? That read about your interest, talk to your colleagues, find out what other people in the department are doing, outline your area of interest, choose a topic, further narrow your topic, identify a research problem, and identify the purpose of the study. Observe what is happening in your environment, be curious, and ask questions. Now, time management is very, very important when we are talking. For postgraduate students, they have a research which has to be completed before their 3 years. So by the time they get all the ethical committee permission and everything, it may already be beyond a year. So they will roughly get a year and a half or 2 years, and their entire research has to be completed between that time. A research report may be longer, like a thesis or a dissertation, or even it can be short, as in case of a journal article or a research paper. But most important is to put a time frame to it. So like these are the steps to planning a research paper. If the step 1 is to define the topic, then is to plan the search, is to search for resources, then create an outline and to write the paper. So you give the first month to define the topic, the second month to plan the research and search for resources, and third month is to create an outline and to write the paper. So within these 3 months, at least this much should be done in a small paper. So the most important problem is formulate the problem, conceptualize, construct an instrument for data collection, select a sample and write a research proposal. So thank you. This is, if you write a very good article, it makes it very interesting, not only for you and your guide, but also for the reader. The reader, your whatever you're writing is from the reader point of view. So therefore the reader has to find your topic very, very interesting and has to be able to read and further do about it. Thank you. Thank you for a very patient hearing.
Thank you very much, madam. That was an excellent presentation. Over to you, Bhagyashri.
Hello.
Yes.
Our next speaker is Dr. Ashwini Kale, ma'am. Ma'am will guide us about other side what editors and reviewers want. Ma'am is IVF consultant and chief embryologist, Asha Kiran Hospital and Asha IVF Center. General Secretary POGS 2020-21, Chairperson AMOGS YTP Committee 2022, Treasurer Maharashtra Chapter ISA 2018-20, Zonal Coordinator AMOGS 2016-18, Peer Reviewer JOGI 2016-18, Ex-Assistant Professor BJ Medical College Pune. Welcome, ma'am.
Thank you so much, Aurangabad OBGY Society, for inviting me. It's always been a pleasure to go back to our parent society. So I'll just start my screen sharing. It's a difficult task actually to speak after Geetha madam. I'll try and live up to your expectations. So my topic for today is what authors and reviewers want, the other side. So basically, once we submit our research, everybody thinks that it should be accepted, or what exactly is the process that goes on, because when you work so much on any manuscript, everybody wants it to be published. So I'll start from preparing to write the work or the manuscript, how you should write it, what all should be selected. I know that has already been covered, the types of paper that are written in the journal, selection of your journal, which is very important because it has to be relevant to your topic of choice or whatever the work that you're preparing. Follow all the ethical guidelines, define authorship, like who will be the first author, the second author, selection of the article, submission process, and then finally the peer reviewer process. So how to start writing? So whenever you think of publishing your work in any journal, like madam just said, that it should be a newer idea. It may not be a wow article, but at least there should be some novelty of the article. The title should be very catchy and interesting, though not very flowery and complicated. And the reader and even the author should find it very interesting, and it should be of utility to the reader who's going to read your article. It should convey an apt message to the reader or the practicing gynacs who will be reading it in a journal, and always put it in a proper context with appropriate references. And don't make it very short or very long, because word count is very, very important in all journals, and write it in a good proper English. Now, preparing to write, as I said, that choose the right kind of a journal which is very relevant to your study. Like I myself practice IVF, so whenever you do some high fundu IVF study or an embryological study, always send it to a journal which deals with IVF and embryology. Or if it is an endoscopy or a laparoscopy, send it to a laparoscopy journal. If it is a general obstetric topic, you may choose a relevant journal. and read the author instructions very, very carefully, because every journal has a defined pattern as to how the article should be written and submitted. Follow it to the T, because that is how the peer reviewers are also guided by, and that is what will be followed by them also before accepting or rejecting your article. Read all the previous issues to avoid repetitions of last 1 year of that has been published in the journal. Like there have been many articles of iron sucrose preparation, oral iron versus FCM, or various preparations of iron, or maybe studies which are related to different dosages of misoprostol for labor induction or augmentation. So it becomes very repetitive, and a journal cannot keep on publishing the same article each and every month. The impact factor of the journal is very important, and use a correct format when you're doing so. The references should be very recent and relevant. Do not take references which are very age old, because we all know that science or even OBGY is an evolving branch. So there are references, newer studies which keep on happening every 3 to 5 years. And choose appropriate co-authors who have done this study with you or who are a part of this research, because this cannot be changed later on, as only the first, second, and the corresponding author get the credit. Now, what are the types of papers which are published? There are various papers, but I'll keep this talk relevant to JOGI. So there are different 11 kinds of papers that are basically accepted and published in JOGI, which can be an original article. The word limit is 2,500. A case report wherein the word limit is 1,200, or it can be about an instrumentation or a newer technique. So you can see that all kind of papers have a specific word limit. So you have to stick to the word limit, which is very, very important. And they have clearly mentioned the word limit. So there are no loopholes anywhere. A short commentary, or it can be a correspondence or a letter to the editor, or it can be a pictorial essay, which is basically nothing but an exclusive, unique, and an exceptional clinical picture of academic or practical interest. Or it can be a systematic review or meta-analysis where the word limit is 3,500, and it should basically discuss, review, and enlighten the readers about all the available literature. And then there are invited review articles, mini review articles, an invited book review, an invited debate. So all these invitations come by the editor-in-chief. Now coming to journal selection. So it should be of your speciality of what you are studying or what you are going to present. It can either be a full-length manuscript or a letter. The journal can either be a subscribed journal or an open access journal. Be very careful when you select such journals, because at times few journals involve a lot of money. So maybe at the end of the day, you'll feel that you've spent a lot of money and nothing is published. Any journal generally takes a timeline of about 3 months to assess your paper whenever you submit it, and also look at what the journal reputation is like. Follow ethical guidelines. This is very, very important. And there is a separate section of compliance with ethical standards on the JOGI journal. If you read it, it's the very first 3 pages, which are very important. Take all the necessary clearances from the ethical board. And it is very important to take these clearances at the start of the study. Do not take these clearances when you are in the middle of the study or at the end of the study, or maybe after 1 year you feel like now I want to publish it, now I'll take the ethical clearance. Don't do this. Take it at the start of your study. Declare conflict of interest, if any. That is, if it is being funded by any company, or if it is sponsored by some institute or some company or some instrument makers. So always declare it. If there's research involving humans and animals, there are a separate ethical clearance that is needed. Informed consents are very important when you are going to publish pictorial pictures of the patients that you have worked on, or maybe rare case findings or rare case pictures that you publish. So always take an informed consent, and always submit it to one journal at a time. Just be little patient. Each journal takes its own time. It can be anything between 3 to 6 months. Don't hurry and send one article to 3-4 journals, because at times if you forget to withdraw it from any of the journals after being accepted by one, you may be blacklisted for doing so, because suddenly it may be published in 2 journals simultaneously, which is not accepted. And give proper attributions to your HODs, to the head of the unit, dean, superintendent, whoever is involved, so that there are no ill feelings later on. Obtain permissions from the institute, be it a private corporate hospital, a government hospital, or a private medical college, before you start the study. And do not fabricate any data. Generally, what happens is when you submit it for the first time, it is a study of 50 to 100 cases. When you try and resubmit it to some other journal, or after a few years, the data just multiplies by hundreds. So do not do that. Whatever the data is, if it is a novel, good, academic, unique study, it will get accepted in due course. Avoid copy paste because plagiarism check is very, very strong. And do not add or delete any name as per convenience, because whenever you submit it to any journal and whenever you mention the co-authors, the email goes to those co-authors as well simultaneously. So you just cannot add or delete any co-author as and when you want to. Then the type of authorship. This is also very important, wherein you have to clearly define who is the first author, who will be the second author, who will be the corresponding author, because these are the only three people who will get the credit. Few journals, even JOGI allows 3 to 8 authors. So see that all their affiliations are very well written, and this is clearly defined when you submit it once, because this cannot be changed later on. And all the authors have to review and submit the letter of approval so that every member knows the role clearly at the start. And this authorship is always earned by what a person contributes. You cannot just dictate to become an author. So the authorship, basically we have to deserve it and not reserve the authorship position. And the contribution to become an author can be anything, starting from conceiving the study, developing this methodology, rendering valuable guidance at various stages, or giving creative inputs, analyzing, interpreting, and evaluating the data, which is also very important. So this doesn't mean that if you have actually involved a statistician in doing so, you have to acknowledge that statistician. The statistician doesn't become the first, second, or the corresponding author. Prepare and finalize the manuscript. Whoever does so, you can include them as an author. Now, coming to manuscript preparation, this is the most important part of your submission, because this is the heart and core of your article. It goes by the mnemonic of TAKAR, that is your title, which should be very informative, accurate, concise, and clear, because the title is the first thing that any reader or even a peer reviewer or an editor first reads it. So he has to feel like reading the entire book. Avoid dramatizing. Do not use very uncommon words, because it's very difficult for a common gynec or a common practicing person to actually understand what you want to convey. The title page should include the title of the article, the first last name of each of the author, their affiliations, email, telephone numbers, city, state, province, country, wherever applicable. Then coming to the abstract. This is the second thing that an interested reader reads. So they want to know in a nutshell what exactly this entire manuscript is about, for them to decide whether they're going to read the entire article or not. So keep this abstract very structured. Mention the purpose of the study very clearly, as to whether your study you have found out a new finding, or whether you have a previous finding which was already has been endorsed by you again by doing the study in a larger group of patients maybe, or if you have amplified that study from an animal model to humans. Mention your methods very clearly, the result and findings with specific data, whether it was statistically significant or not. Conclusion, do not use any abbreviations or unspecified references. Coming to keywords, this is again very important for indexing your journal. At least 4 to 6 should be there, and always use the mesh, that is the Medline subject heading words, which are available on the Medline website. And the text formatting should always be according to the journal. It cannot be according to your liking of any font or color. So they clearly mention the font size, and the color is always black. Do not use fancy colors and fonts in your keywords or text formatting. And save the document in docx, which was the previous Word format, or the doc format. Coming to headings and abbreviations, not more than 3 levels of headings are accepted, and abbreviations, if you want to use and they are of need, so always define them at first and keep on using the same ones consistently. Do not keep on adding abbreviations at each and every paragraph or every new page. Footnote and acknowledgement. So this gives an additional information. Do not include any figures or tables in this, and it should not contain solely the reference citation. And always acknowledge all the people who are involved in your research, your manuscript, or your letter writing, all the patients on whom the study has been done, the data collection compiling people, or if there are any conflicts of interest, if it has been funded by any company, pharma. So always mention that in full. Do not use short forms or abbreviations there. Now coming to English, this is also very important, because many papers have seen where the English is not very correct. Maybe the content is very good, but what they want to convey to the author or the peer reviewer, nobody knows. So the grammar, spelling, punctuation, terminology should be very good and correct. It may not be a high fundu Shakespeare play that you are writing, but at least the English grammar, spelling, punctuation is very important. Keep it very simple. Don't use any flowery languages or any thesaurus kind of words, but they should be easy to understand. They should convey to the author what you are actually writing and doing, and do not use any slang short forms in your writing. Short sentences are preferred, which are logical, relevant, and clear, which are easy to read and understand. The scientific style, always use International SI unit. If need be, to use generic medicines or chemicals instead of trade names, always prefer writing the generic names. But at times, if you want to write the trade names, which may happen in cases of like an example of a PGE2 gel that you want to use, you want to write the trade name. So write the generic name first and then the trade name. Coming to references, this is again very important because this is how your article is, how you have referred it. So number them in order of the first appearance that they come in the text and not as per alphabetical order. And once a reference is cited, the subsequent citations should be to the original number. And these do not appear unless you cite them. So be very, very careful and thoroughly cite them properly, because the number jumping should not happen, that you have put in a reference number 1 on the top, then number 2 at the bottom, then again middle number 3 comes. At times 1 or 2 references may be repeated one above the other, but see to it that they are in order. Always use the form of references which is adopted by the US National Library of Medicine, which is as an Index Medicus, and use et al. Whenever there is a long author list. So what is the basic acceptance criteria in any journal? The work should be relevant to the journal scope. This is what any journal editor-in-chief or peer reviewers would want, that the article that you submit is relevant to their subject. The results should be significant to the field. The discussions and conclusions should always be supported by good relevant data. The work should be placed in proper context, and the equation, figures, or the tables, diagrams, all of these contribute to the presentation. Well written and a logically organized manuscript is always the one which is very attractive and pleasing to the editor also. So the submission process has become very easy. It is an online process. You do not have to send any manuscripts by courier to the office or anything, and everything is auto acknowledged at each and every step. You are guided. You just have to log in as an author, complete the required formalities. You receive a copyright form submission link, auto acknowledgement is sent, and an official submission follows. So now starts the peer review process. So there is an initial quality check which is done by the staff of the JOGI journal, editors and the secretary, and then it comes to the editor-in-chief. The editor-in-chief assigns appropriate associate editor or national corresponding editors, and associate editor handles the manuscript, and then they contact the peer reviewers. The peer reviewers may take approximately 15 days to analyze the article. Mind well, this is all a double-blinded procedure. So except the editor-in-chief, none of the peer reviewers know who the author is. Neither the authors would know that who the peer reviewers is. So there is no bias here in selecting, rejecting, or accepting any article. So never take it very personally when it is rejected or accepted, because it is a very, very transparent process of accepting only articles which are of highest academic interest, because it is a double-blinded procedure. Wait for the reviews from the peer reviewers for the first decision, or at times even the editor-in-chief may make a final decision. The peer reviewers either suggest minor, major revisions, or may suggest to accept as it is or directly reject it. The reviewer recommendations come in the form of accept as it is, minor revisions are needed, major revisions needed, or rejected. Regarding the manuscript decisions, the editor makes the final decision after the peer review process is done. And if revisions are requested, the author gets 15 days to do so. Mind well, take these suggestions or whatever corrections that come from the reviewer very, very seriously. Take each and every point correctly, and each and every point has to be explained well and satisfactorily, so that you just get one chance to correct all this, so that it is not rejected. And whatever the peer reviewer has asked, it is to the point, so answer it to the point. You may refer, the editor may refer back the review to the same or a different reviewer, and if the reviewer is satisfied with explanations, the same is conveyed to the editor. So as I said, that take each and every point very seriously. If there is a need, you may put in additional tables, figures to explain whatever the query has come in from the peer reviewer. If you have to write an additional reference or an additional table, just take certain efforts to put it in, and be very polite and courteous when you reply. because none of the peer reviewers know who the authors are. So there is no personal vendetta that has been taken out, no personal agenda. They just look at the article like from the journal's point of view also, because they also have people whom they have to answer. The article should be relevant to the journal, to so many readers who are there. And it is for the benefit of both the journal reader and the author. So always take it in a positive way. And it is a good way of rethinking and rewriting your article. And don't keep on complaining to the journal that my article is rejected or this query is asked. Whatever is being asked is very transparent. See to it that whenever revisions are asked for, that you submit it, you reframe it, or you rewrite it, whatever is being asked, instead of complaining, because many of the complaints are just turned down. And think of what and where you went wrong rather than blaming the journal ki why they rejected my article. So whenever they give you some comments, please take it very seriously, because they are given by reviewers after a lot of thought process. All this peer review process is all a voluntary job. None of the peer reviewers are paid. So they actually take out time from their busy practices or from their busy schedule to look into it, to read it, to go through all the tables, figures, to see whether the references are correct, whether the statistics is right, whether it is significant. So take it very, very seriously. I'd like to conclude by saying that conducting and presenting a study are two spectrums of the same rainbow. Because if you conduct some study and you do not present it, then nobody would know what kind of a study you have done. And if you just present a study without actually doing it, so it is just fabricating data, do not indulge in unethical practices. Always read the author guidelines and follow them to the T, because each journal has defined their scope and they have clearly mentioned the author guidelines. And that is what is followed by the editors and the peer reviewers also. Choose the journal very wisely. See to it that it is relevant to the kind of work you have done, so that you wouldn't feel bad that your article is rejected. And in case, even if you get rejection from one journal, take out time, think twice as to what went wrong. Maybe if you have a chance, rewrite it, resubmit, rethink it. And trust me, writing a journal or a manuscript really takes a lot of time. So invest in this time and be very ethical to avoid blacklisting yourself. So research is nothing but formalized curiosity. It is poking and prying with a purpose. So do not stop writing just because one journal has rejected. I myself have faced a lot of rejection from Jogi journal, but I finally understood at the end of the day that it is a very, very highly academic platform wherein the article has to be very specifically written, very specifically oriented, and it should be very relevant. So that is how it finally gets selected. Thank you so much.
Thank you, Dr. Ashwini ma'am, for excellent talk, for enlightening us. Now our next speaker is Dr. Vani ma'am. Ma'am will impart us about ethical principles and guiding research. Ma'am is MBBS MD from AMC Visakhapatnam, multi-medalist in UG and PG, presently Professor Obstetrics and Gynaecology GMC Srikakulam, 42 paper publication, won best paper twice in a state conference, speaker in many national conferences, fellowship in advanced course in medical education. Welcome, ma'am.
So thank you so much for calling me, and sorry for the delay.
Actually, madam, we are very thankful to you, because at the last moment you have accepted. Kavita madam couldn't join because of some family emergency. You have taken up her topic at the last moment. Yes, 1 hour prior to the to her talk. So thank you so much from our side, and welcome,
Okay,
madam.
madam.
Yes.
Okay, madam. Okay, madam. So good evening, everybody. So PGs are there in this platform?
Yes, ma'am. Yes, ma'am.
Right. Okay. So I think this is the last topic of the Picsep workshop, ethics in medical research. So this topic I would like to deal in two parts. Next slide. So the first one is regarding the publication ethics, and the second one is regarding the actual ethical aspects which everyone have to follow while doing a research project. So the learning objectives at the end of the 20 minutes of the session, I would like every participant to know or to recognize the various ethical issues related to publication. And the second one is to make use of these ethical guidelines, which are available at the national and international organization in your publications and in future research. So with this learning objective, the next slide. The 6 important components of publication ethics are, the first is the ethics review or the breach of confidentiality. So it is very, very important. The second one is what is called as fabrication and falsification. The third one is regarding the authorship issues. Fourth one is regarding the plagiarism. And fifth is related to ethics, which is related to submission issues. And the sixth one is regarding the conflict of interest. We'll go ahead into each of these in depth in the next few slides. First one is regarding the breach of confidentiality. We all know that human research is always, it has certain ethical issues, and all human research as per the national guidelines have to be endorsed by ethics committee approval. The second important one is regarding the informed consent. Whenever we are dealing with human research, informed consent is mandatory. It is a must when we are conducting research on human participants or on trials. So what are these trials? If we are conducting any trial, like any intervention, either it could be a pharmacological agent or a surgery or any administration of a drug or any procedure. So any of these research should be registered with Clinical Trial Registry of India. So this is an organization which will give the approval for all the research trials involving the human beings. So this is again another very mandatory part. The third one is regarding the data confidentiality. Without the institutional permission, one cannot share the data with someone for analysis who is working in a different institution. So this is also an important point in the matters of confidentiality and the ethics review. Next slide. The second important aspect is regarding the data. The data should not be fabricated or should not be falsified. So what are these two terms actually mean? The two terms actually mean, if the research results are not generated from the original study, then you call it as a falsification. And or if the results are generated by manipulating the data, then it is called as fabrication. So I think you understood the difference between falsification and fabrication. I'll give an example also. This is an extremely serious misconduct, and all the case report forms and the data should be preserved for the future purpose to dictate any fabrication or falsification. Next slide. So here I'm giving an example of what exactly is falsification and fabrication. So I had recently a final year PG student who came to me requesting to analyze the thesis data. And then when I asked him from where he got the data, so he says that the data was only cooked up and it was not derived from the original part of the study. So this is what is called as falsification. So wherein the actual data is not from the study itself. So this is what is called as falsification. The second one is, when I again asked, from where did you get this data? He said, I collected from the senior thesis. So this is what is called fabrication. So he has stolen the data from the senior PG thesis and is trying to modify or manipulate the data for his convenience. So this is what is called fabrication. So these two are serious ethical misconduct. Next slide. So this is not in our country only. Fabrication and falsification of data has been an important point of ethics, even at the international level. So recently I found that a member who was a part of the research team, which was led by Nobel laureate, so it is something a part of the stem cell research, was also found guilty of fabrication of the data. Next slide. The third important principle regarding ethics in publication is authorship. So this is very, very important. Authorship means it is conferring credit to an author. So authorship confers credit. It implies the responsibility of the author and accountability of the published work. So each author who is mentioned in the publication should be clear about their responsibility, and it is mandatory to declare the contribution of each author in a particular publication. So this decision on authorship should be at the beginning while writing the protocol of the thesis itself. Next slide. So the criteria for authorship, who should be given authorship? When anyone has given a substantial contribution, either in the conceiving the idea or in the designing of the work, or in the acquisition of the data, or in the analysis of data, or interpretation of the data. So when any person is involved in any of these activities, then we can confer or contribute to the authorship. The second one is, if any person is involved in the drafting of the work, or revising the work, or critically appraising the work, then also you can confer authorship. Or when a person is involved in the final approval of the version of the published, or in agreement to be accountable for all aspects of the work, including the questions which are related to accuracy and the integrity of the data. So all these persons who are involved in any of these can be conferred authorship of the publication. Next slide. So this authorship is important because we find in many cases what is called as gift authorship or ghost authorship. That means these persons are not involved in any of the aspects of the research work or the work, but they were their names are included in the paper or in the publication. So this again accounts to a serious misconduct. The fourth aspect is the ethics related to submission. So here, please see the words which are important. First is what is called simultaneous submission. So it is not correct to submit the same manuscript simultaneously to two different journals. It amounts to a serious misconduct. The second one is what is called duplicate publication. That means submitting a new manuscript with the same idea, same hypothesis, same data, but with slightly paraphrasing the sentences. That is what is called duplicate publication. The third one is self-citation. That means citing his or her own publication out of the context. The last one is what is called predatory journal submission. That means these journals, they hardly have any peer reviews. So when you are submitting to such a journal, these journals are called predatory journals. So simultaneous submission, duplicate submission, self-citation, and submitting to predatory journals all come under ethical misconduct in the publication issues. Next slide. The most important one which all the PGs have to learn is regarding the plagiarism as a very, very serious misconduct. So what is plagiarism? To define, it is the use of previously published manuscript by someone else as if it is his or her manuscript, or unreferenced use of others' published or unpublished ideas without taking their consent or giving them credit or giving them acknowledgement. Any of these they come under the purview of plagiarism. And the most common form of plagiarism is copying. Is copying text word for word. So this is considered as a serious publication misconduct. Next slide. There are three important types of plagiarism. First one is called direct plagiarism. That is, it is complete cut, copy, paste. It is either complete or partial copying without acknowledging the original author. The second one is what is called self-plagiarism. It is nothing but the duplicates of the previous work or sentences. The third one is what is called redundant publication, or otherwise called as salami slicing. What is this? It is actually a single work, but the same work is broken into parts and it is submitted as if it is as if each one is of a different work. So this is what is called salami slicing or redundant publication. Next slide. So how to avoid plagiarism? Basically, so one has to avoid the cut, copy, paste behavior, and then write the concept in his own words. So this will require a lot of time, and acknowledge the original source, even if it is an unpublished work also. Please acknowledge the original source and cite the references accurately, and use anti-plagiarism software tools. So many tools are available, and every university has their own anti-plagiarism software tools, so which all the PG students have to use them before submission. So use of anti-plagiarism softwares. Next slide. The sixth important issue regarding the ethics is conflict of interest. So any financial, personal, social or other interests which directly or indirectly influence the conduct of the author with respect to the manuscript have to be disclosed. For example, recently I have given my PG a thesis regarding carbitocin usage. So this was sponsored by pharma company. So therefore, this PG has to acknowledge or has to declare the conflict of interest that this was a sponsored one from the pharmaceutical company. So this is what is called declaring conflict of interest. So any conflict should be disclosed during the submission. That is a mandatory process. And the readers can determine the influence of such a the conflict of interest on the conclusion of the paper. Next slide. So having understood what are the ethical misconduct rules, let us see what would be the consequences of a serious research misconduct. So there's an organization called COAT. It is Committee on Publication Ethics, which describes the consequences of a serious research misconduct. So this can depend on which type of misconduct, whether it is major or minor. The author can be blacklisted by the member journals, and the institute can take action. So many consequences are there for serious research misconduct. Next slide. So therefore, whenever you're doing a research work and before submission, we have to have a checklist. So what is this checklist? Right from the approval and consent. The second part is the data accuracy regarding falsification and fabrication. So that everyone have to have a double check on the data accuracy. And then regarding the plagiarism and self-plagiarism, we have to put into the anti-plagiarism software and check. Next slide. Next slide, please. Yes. So the second part of my lecture is regarding the ethical framework for health research. So whenever human beings are being involved, we have to follow certain ethical rules. Next slide. Among them, so any research involving the human participant should follow some national and international standards of ethics. The Indian national standards are also very stringent, and these Indian national standards are dictated by ICMR. The ICMR has given in 2017 the latest version of ethical guidelines involving the human participants. Apart from this, every research work has to be approved by the Institutional Ethics Committee or Institutional Review Board. So these boards are there for every medical college and institute, and it is necessary or mandatory for, so before doing any work, should obtain the consent of the Institutional Ethical Board. Next slide. As I've said, ICMR is the apex authority which has given the guidelines for research on human participant in 2017. So it has given in 2002 onwards, and 2017 is the revised and the latest version. So it is available on website. It is very much mandatory for all the PGs to go through the ethical principles which are dictated by the ICMR. Next slide. All the researchers should follow certain basic ethical principles. So this I would put in the A, B, C, D, E rule. So 5 principles, A, B, C, D, and E. A is equal to autonomy. So autonomy means the patient decision is the final. Suppose a human participant, so he is the ultimate authority to consent himself whether to participate or not to participate. So we have to respect the autonomy of the participant. So this is what is called autonomy rule, that is the A rule. The second rule is beneficence. The second rule is beneficence. Whatever work is being done should be of benefit of the to the human participant and to the society at large. So this is what is called the ethical rule of beneficence. The third one is called as confidentiality. So whenever we are doing any work on human beings, we should keep the data of the participants confidential. So that is what is called C rule, that is the confidentiality. Then the fourth rule is the D rule. D rule is nothing but do no harm. So whether we are doing benefit to the participants, it is not important, but first thing is we should not do any harm to the participants involved in the study. So that is what is called do no harm rule, or same thing is called non-malfeasance. So this is the D rule. Then the E rule is what is called equity or justice. So whenever we are conducting a human trial, so whatever resources are available should be equally distributed to all the participants, irrespective of the caste, creed, race, gender, etc. So this is what is called equity or justice. So hope I'm clear with the ABCDE rules: autonomy, beneficence, confidentiality, do no harm or non-malfeasance. E is equity or justice. So every researcher should be aware of these 5 basic ethical principles involving the human research subjects. Next slide. The next one is what is called informed consent. So any human trials should have an informed consent. So what is this informed consent? It is the process of informing the potential participants about the proposed research work. So how systematically it would be done, and empower the participant to make their own informed decision or refusal, whatever could be. Informed decision either to participate or refuse to participate in a research. So this is what is called informed consent. So here all the participants should understand the study procedure. They should understand the risk and benefit. get all their queries and concerns answered, and then take a learned and an informed decision or a refusal, whatever. So this process can be repeated several times while in the research study if necessary. So this is what is called informed consent. Next slide. So this is the format of informed consent. So which involves in the, so the consent form, the top part should be it should be an appeal or an invitation to participate in a research study in a simple, easy, understandable in the local language. The middle part should have the research description, the risk, benefits, alternatives, confidentiality, compensation if anything happens, and then the contacts and the voluntary participation and withdrawal. So this should be in the middle part, and in the bottom part should have the signature of the participant along with the witness who is not a part of the study team. So this is how an informed consent document should be present. Next slide. And as I've said that every institute has an institutional ethics committee or a review board. Whatever study we are doing, so whether it is involving the human subjects or not, so whether we are doing clinical trials or not, every research work, even if it is a retrospective work, should have an approval by the institutional ethics committee. So this is mandatory. And then next slide. The main responsibility of institutional ethics committee or any review board which is attached to institute will see whether the study has a real or a potential benefit, or the rights of the research participants adequately addressed, and does the potential benefit far outweigh the risk associated with the research participation? Will the participants and communities have access to the study findings and the benefits of the research? And what is the mechanism of provision of the safety and care of the research participant? So all these will be intricately reviewed by the institutional ethics committee or the review boards. Next slide. So I think this is the final slide for me. So ethics in conducting a research and ethics while publishing the data are very, very important. There are so many challenges, but whoever is doing a research work, either a PG or a faculty member, should be doing the research work within the framework of these ethical principles. Only then the society will be benefited at large, and the human participants who are involved in any research activity would have the benefit of this research, and then their concerns will be addressed. Next slide. So thank you very much. So hope I'm clear with the two parts of my talk, the publication ethics and the ethical principles involved in human research. So thank you very much for giving me the opportunity.
Thank you very much, Vani ma'am, Dr. Vani ma'am. Very informative talk. Today's webinar was excellent with valuable knowledge. Thank you very much to all speakers, Dr. Geetha ma'am, Dr. Varsha Deshmukh ma'am, Dr. Sushil Chawla sir, Dr. Radhika ma'am, Dr. Preeti ma'am, Dr. Kiranmayi Devineni madam, Dr. Pradnya ma'am, Dr. Ashwini Kale ma'am, and Dr. Vani ma'am. I am thankful to Aurangabad OBGYN Society President Dr. Anuradha Shewale ma'am and Secretary Dr. Gurpreet, Convener Dr. Ajay Mane sir, Coordinator Dr. Manisha Pathrikar Kakade. Thank you very much to all delegates. Then thank you Dr. Amit sir and Dr. Deepika Chhabra ma'am from Jagsonpal Pharmaceuticals for giving us platform. Thank you very much each and everyone for making this webinar successful. Thank you.
So thank you all very much.
Thank you so much. With that, we would like to end the webinar.